See, I don't know why mine's not connected.
Do you want to use mine?
It's not connecting. Oh my God. You don't have my slides.
It's all on the drive, right?
I don't know. Up. Yep, I guess it is. Quick access.
Where did you put them?
They're up here. You know, from this last week. You edited today. I didn't do that one. I edited this week. Let me see if it's got my stuff on it. I'm going to do random check here on notes. So, yeah, I guess it's on the drive. See, it says I've got a good internet connection.
Yeah, but see, mine aren't showing up either.
I'm not getting on.
Okay.
How did you upload the slides to the lectures?
So I went into the slide,
Okay.
and then I like open it,
Okay.
and then go back to those three dots. And I did, well, I did it on my computer. And I did make a copy. Oh, you know what? Go back to the, I'm sorry, don't go to slides. Go, well, are they, let's see. Try that again. I'm going to share and export. Make a copy. And when I did that, it gave me
Well, the problem is not my slides right now. My
it's
problem
just being able to log in.
is being able to log on. Bring my phone in here if you don't mind, please. Thank you. Okay, so I can't get on.
Well, here, you can use mine, but the problem
We'll just
is...
stay at your house if you don't mind.
That's fine.
Does that make it easier for you or worse for you?
Oh, no, it doesn't matter. Whatever's easiest for you.
What else do you want to know?
Okay.
Turn this off, maybe. Printer. I can't get on. Damn it.
Do you want me to try on my computer?
Yeah, if you have, I can't get on all of a sudden. I've been doing this all, I got on, and then once I got off of it.
Well, we just need to find a way to get your slides. I'm on.
Maybe that's why I can't get on, no wonder.
Ew. Do you want me to log out?
Can you log out just a second and let's see what happens when that. So you're just sitting there.
Yeah. So, you want me to hang up again?
I don't think it makes any difference, honey. Says your term was terminated unexpectedly. Check your internet connection or try again.
I hope we don't get kicked off during.
No, wait up. Do you have my slides on your drive?
No.
Well, Jeff should have them, I guess.
Yeah.
Hello?
This service is provided by freeconferencecall.com. There is one other participant in the conference. The recording has started. Please announce yourself.
Becky Austin? Terrible echo.
Wait, let me see if I hang up.
Hello? This is Jeff. Do we have anybody else on?
Vann is in the room with me.
Okay.
We can't have our,
I'm getting about every other word. Are you where you guys can get on a phone, a landline and dial in?
yeah.
Okay. Because it sounds like it's having trouble. Oh, those are some weird sounds.
I think it's my faint ceiling fan, to be perfectly honest with you. I think it was a problem last time. Better?
Kurt's here.
Okay. I also...
Becky Austin.
Hey, Becky, I'm going to make you the presenter.
Okay.
Uh-oh. You must have two lines open because I'm getting feedback.
I called in on the phone, so I'll hang that up too. Hang this one.
Or maybe mute your... mute your computer speakers.
Okay, and Kurt's with you guys too.
Okay.
Can you hear me?
Yep.
All right, I'm a little hoarse today, so I'll just be quiet mostly and listen.
Stone Winnie.
Tracy Amadon.
Hey, Tracy. Uh-oh. Sorry about the bird.
Oh, there's always background, something interesting in the background.
I'll go on mute in a minute.
Hey, Jeff, I'm assuming that I don't have an account for this free, whatever it's called. So do I just need to register for an account?
You don't even need to do that.
Okay.
You can use the one I set up for Ski Apache OEC.
Oh, okay.
I'll send you the link, and the password is the most famous ski patroller.
The most? That's actually the password?
Yeah. Well, no. I mean, think of who it would be.
Oh gosh.
The candidates should know by now.
Most famous ski patroller. Jeff Rollin?
No. No. The first.
Oh, oh gosh.
Uh-oh.
Minnie Dole?
There you go.
Okay.
I'm trying.
I almost said Minnie Mouse, but I caught it.
Oh, yeah. Well, Minnie Mouse is okay. I'm trying to get the two people, the two new additions on the line. So.
Okay. Yeah, I think I sent both those to you. Did I send you David Watzek?
Yep.
Okay.
And Eve?
Yeah.
Okay.
Those have been the last
yep,
two. And I'm changing it so that they come right to you as well. I'll add you.
Okay.
So I'm not having to I just need to go into the the website tool and do that.
Okay. Gosh, what is the... Oh, wait, I can just email it here, right? Here we go. Oh. It's going to Outlook. Hey, Becky, are you sharing? You need to share your screen?
Yes, I accepted your sharing invitation.
I mean, so are you looking at console?
I am looking at a Google.
Oh, no. So for now, are you at freeconferencecall.com?
Yes,
you should
I
be.
am.
Okay. And then, so I gave you control?
Yes.
And I think you should have like a, it looks like a play button on a VCR. And that should share your screen.
Let me see. No, that's Lee. Let me see what that one. No, I'm not. I don't see what you're talking about, Jeff. I'm sorry.
Are you in the app or online?
I'm in the app.
Gosh, you should. Let me try it again. Maybe it didn't.
Okay.
Take. Come on, where is everybody? I had you. Yeah, you're the presenter.
Yeah, I can see it says Becky Austin, presenter.
Oh, you can't? Oh, yeah. But do you see her screen?
Oh, no, I just see a Google screen.
That might be her.
Let me try to pull up my slides and see.
Okay.
And I don't know if you guys ever noticed this, but if Becky, you're on your computer, if you have the sound, are you on talking through the computer or on the phone?
Well, I have both open, so which one should I do?
Well, I think it's okay if you talk through the handheld, your phone, but just make sure you turn the sound down on your laptop.
Yep.
Oh, okay.
Because I hear like an echo.
Okay, do you hear an echo now?
Nope.
I think it's better.
Yeah, I just turned my sound off, and I'm muted on there. So what do you see on your screen now?
I still just see a Google landing page.
Is that what you're sharing, Becky?
No,
oh, yeah.
today I'm going to share respiratory emergencies, and you should see a goofy little kid. You should see my slides.
I think you shared just your web browser.
Okay, so what do I need to do then? I'm not sure where to go.
Click on, I can't see it because it took it away from me when I gave you control, but it should look like a play button. Do you see that? Oh, I apologize.
I do not see a play button.
Here, I'll tell you what. Let me take back control for 1 sec.
Okay.
And then, so mine.
I wonder if Becky, could you just open a file? Maybe had you opened something yet?
No, I mean, I opened my slides from Google Slides. I was hoping you would see it when I did that.
Oh,
you know what? Maybe. Well, let me try it now. I turned off screen sharing, so it should be blank, right?
Yeah, it just says waiting for presenter to share their screen.
Yep, and then when you should get a play button there, and it didn't give me a choice this time. Hang on, I'm sorry. Normally when I click on share, well, I guess it's just going to share my entire monitor now. Do you see like Google Gmail?
Uh-huh.
Okay.
See, I don't see anything but freeconferencecall.com.
I see your Gmail.
Okay, weird. Now it should have gone away. Let me hand it back to Becky.
I wonder if Becky lost her connection or something.
No, it's showing me recording.
Yeah, recording is just, it'll record the call and the video. So now you're the presenter and you should be able to click the play button.
Right now it took me back to the Google landing page.
Okay.
I don't have a play button. I have Vann here sitting with me trying to help figure this out, but hit that one again.
Let me do this. Oh wait, I see your screen, but now I'm still seeing Chrome.
Now try to flip your slides. Let me try to pull up my slides right quick.
Okay.
Now what do you see?
No, I think you only shared the application.
Instead of her desktop?
Yeah.
How do you? I don't know. That's where I am. I just see the Google landing page still.
Well, I'll find your slides. Worst case, I'll just run them for you.
Okay, that's fine. That's fine with me, Jeff.
Okay. So are you starting with 13?
Starting with 13.
Okay.
My initials are at the beginning of each slide set that I will be using tonight.
Okay.
You'll see BA.
Hang on. How do I guess I have to download it first. Give me 1 sec. And so let me take back control. You just have to tell me when to switch.
That's fine.
Is everybody seeing the PowerPoint? I hope. Oh, no, you're not. Now you should see it. Everybody have the PowerPoint?
Yes.
Okay. Actually, what we should... Oh, no. Oh, dang it. I just hit update. All right. I think we're good. I'm going to do it old school because... All right. We'll just do it like this. Okay. And then just tell me when to switch. And whenever you're ready... I think
okay, do you have BA Chapter 1314 lecture open?
Yes. Do you see it?
Okay. Yes, I see it. You should be seeing the first slide, respiratory emergencies.
Yep.
The little kid on that screen?
Yep.
Okay. First of all, very excited. Can't look forward to the ski. I look forward to the ski season and meeting all the new people. My name is Becky Austin. I am an instructor candidate, so bear with me. You guys should be looking forward to some fun times on the mountain. But today we're going to talk about respiratory emergencies. So I hope everyone has had a chance to read this chapter because it's probably one of the most frequent emergencies that you're going to be treating on the mountain. So first question, who can tell me why I have a picture of a little boy on this page? Okay, I'm going to
probably more common to have asthma.
No, it's his tongue, actually, because what you're going to learn, the tongue is probably one of the most frequent causes of obstruction in the respiratory tract that you could possibly run across, or actually one of the most frequent obstruction. Second slide.
Becky, I'll answer. This is Tracy, and then I'll be quiet. I won't answer again, but it's doesn't it also have to do with the fact that for a child the tongue is bigger proportionately than like an adult tongue?
Absolutely. Absolutely. Thank you, Tracy. So can we go to the next slide? So the next slide, the next 2, 3, 4, 5 slides are going to be objectives, and we're just going to breeze through those. So take a peek and look at all of those because you're probably going to, these are some of the key objectives that you must learn out of this chapter. You must have a real clear understanding of diffusion, dyspnea, respiration, be able to have an understanding of the major anatomical structures. We'll just go, the next slide, number 3, again, is a list of objectives. Now, I know this is a lot of bullet points and rather boring, but I feel when you read these objectives, it gives you, again, a clear understanding of what you should be learning from this chapter. Because, again, every chapter will be on your test. There could be anywhere from 2 to 3 questions from each chapter, maybe major chapters even more. So pay attention to your objectives. So, again, slide number 4. You should be able to understand the list, the size of the symptoms and the acute respiratory distress, and be able to list signs and symptoms of following respiratory emergencies. Many of them were already, most of you guys are probably very acutely aware of. So we'll flip down to slide number 5. You should be able to learn to demonstrate how to access a patient who's having difficulty breathing, and then be able to demonstrate how to appropriately take care of that patient. Slide number 6. You see a mother and possibly a child there, and I think this slide just demonstrates that we're going to encounter patients of all ages, shapes, and sizes. There'll be alpine skiers, there'll be mountain bikers, hikers, and it will just be family members coming up to the mountain to enjoy the mountain with their family. Now, I think sometimes respiratory difficulty can often be somewhat of an objective complaint, but kind of my rule of thumb is if a patient tells you they cannot breathe, then you believe what they tell you they can't do, and that's where you begin your assessment. If they can't breathe, although it may not be quite obvious to you, then they probably are having respiratory difficulty. Again, respiratory emergencies are going to be some of the most frequent and probably can be the most urgent emergency that you're going to come across on the mountain. So now in this chapter, we're not going to cover airways, we're not going to cover the various methods of delivering O2, but you will have the opportunity probably this coming weekend to look at some of that and discuss respiratory emergencies at greater depth. So the next slide is number 7. And this is just a very simplistic cartoon of our anatomy and physiology of our respiratory system. And it kind of points to two things. First of all, our systems are all interrelated. They require each other to be able to function. Pulmonary, without pulmonary function, you'll have no heart function, and vice versa. And in the small circles there, can anybody tell me what those two small circles are showing us?
Diffusion?
Diffusion, exactly. So within the alveolus, that's where you have the CO2 and the O2 being exchanged within our body. So that is diffusion. So again, if you go to the next slide, number 8, if you look, again, another very simplistic cartoon, but it tells us a lot when you look at this slide. First of all, it shows us the airways. So anybody can say what is the sequence of air as we bring it in through our nose or our mouth?
You might see that question again.
Yes, test question here. So it actually comes into the larynx, the trachea, the bronchi, and it ends in the alveoli where diffusion takes place. So if you look at the lungs, they sit in the thoracic cavity. And the lungs are encased within that cavity. And the workhorse muscle is the diaphragm. So that's really where the intercostal muscles and the diaphragm probably are what I call the workhorses of our respiration. But when you look at neck, you look at shoulder, your chest, and abdominal, what you really have, those are called accessory muscles. And those muscles begin to work and help the patient breathe when the body is not getting enough oxygen. So some of you guys who have some medical backgrounds, you've probably seen patients that have used accessory muscles in their neck, in their shoulders, in their chest, and we'll talk maybe a little bit more about that. But each one of the lungs sit in a pleural cavity. And those cavities are lined with a double-walled tissue, and it has fluid in it. So the visceral pleura lines the outside of the lungs, and the partial pleura lines the outside of the thoracic cavity. So many of you have heard of patients that have had pleurisy. So it's within that wall that pleurisy occurs. The friction is caused for whatever reason. It could be in numerous reasons as to why. But that pleural cavity and that lining is very important. So we'll talk about that a little bit later. But again, the intercostal muscles, the diaphragm, and then your accessory muscles are all very important. But if you see patients having to use accessory muscles, such as in their neck, that means you're not getting enough of oxygen, and it actually can signal your first indication that patient may go into respiratory arrest. Who can tell me how many cycles does respiration have? Test question. Okay, inhalation and exhalation. So we'll go to slide 9.
I would answer, but I keep muting myself.
Oh, I know. Vann keeps telling me this, but she's also timing me, so I'm trying to breeze through these.
Hey, Becky.
Yes.
I have one question. Can you tell us how, when you breathe in, what is the diaphragm muscle doing, and when you breathe out, what is it doing? Because that may be something that we'll see frequently.
Okay. Well, that's a good point. If we all take a deep breath in, what do we feel the diaphragm's doing? Contracting?
Hey.
And when you relax it, and when you breathe out, what does it do?
Relaxes.
So that brings up a good point. If you put your hand on your own diaphragm and you feel it move, that's a good indicator too when you look at it to see how well that patient is able to, how well they're able to use those muscles or that diaphragm to breathe. Does that clarify it, Jeff? That's actually a test question.
Yeah. So I think the way to think about it for answering the test question is when you when the diaphragm relaxes, it expands, and it occupies more space in your chest cavity, and that makes you breathe out because it's taking up the space the air used to take up.
Oh, okay.
When the diaphragm, when it contracts, it gets smaller, and it takes up less space, and now there's a vacuum in your chest, so it has to draw air in. And it's almost a trick question because a lot of people get confused. You think it's the opposite. Anyway.
Any questions on that? Okay, let's go to slide 9. Common respiratory emergencies. Now, I've seen every one of these on the mountain. So these are actually things that you're going to see. Obstruction and choking. We talked about that. Bar patrons that drink too much, they pass out. COPD. Most people with COPD are not going to be skiing, but we're going to have older patients, patients with chronic obstructive pulmonary disease. They're going to be up in the mountain, have never even given a second thought to what the altitude must do. Asthma, hyperventilation syndrome, pulmonary embolus. Most people think of a pulmonary embolus from your typical causes, sitting too much, constriction, but also pulmonary embolus can be a concern too when you have large bone fractures like your pelvis and your femur. They can produce what they call a fat embolus that could go to the lung. Spontaneous pneumothorax. Remember we talked about what the lungs are encased in the pleural cavity. So if air gets in that space between the partial and the parietal, in the visceral lining of the lungs in the thoracic cavity, then you're going to have a lung collapse. We've seen that. And that's something that's actually kind of not unusual in young men for whatever reason. So there are a lot of respiratory issues that we're going to see up on the mountain. And I've seen actually, well, I've never seen a pulmonary embolus, but it's always something you keep in the back of your head when you're beginning the assessment of your patient. Other causes can be infection, and of course one of the biggest things that we treat, and the most frequent respiratory emergency, or not emergency, but is altitude sickness. But for some patients it can be. Number 10. So what's really important is beginning the assessment of your patient. So how do you describe respiration? If you had to describe it, what are 3 things that you're going to describe? You want to know what is their rate? How many times are they breathing? What is the rhythm of their breath? And what is the quality of their breath? Are they able to get enough air in and push enough air out? Again, that may require you to look at it. What is the hallmark of any respiratory emergency?
Tripod position?
No, dyspnea. Dyspnea, or difficulty breathing. That is considered to be the hallmark of a respiratory emergency. Tachypnea. Does anybody know what that is?
Tachypnea.
You should be able to guess from last week. Remember, tachy is fast.
Tachypnea.
Brady is slow. And anything to do with PN in it means air or breathing.
So
the way I remember Tacky and Brady is that the Brady Bunch was retarded, so they're all slow. And it's tacky to go fast.
So tachypnea would be a respiratory rate of greater than 30 in an adult, and we'll talk about the different rates. And bradypnea would be a respiratory rate of 10. So you've talked a little bit about primary assessment. And when you have a patient, your primary assessment is always going to be your A, B, C, and D. You're going to look at their airway, breathing, circulation, and the disability. Now, look at your patient. Now, we use pulse oximeters on the mountain all the time. You probably may end up wanting to go ahead and buy your own. But remember, if you use your pulse oximeter, don't treat the number on the machine. You treat your patient, and you do that by looking at them. What is their level of awareness? Are they using accessory muscles? And if you see cyanosis, which is the discoloration, the bluing that is actually, and I know some of y'all have some good strong medical background, so I don't mean to insult you, but if your patient is turning blue or turning cyanotic, that means their oxygen levels are probably down in the 60% already. You obviously have a patient that's in trouble. Other things that you might look for: what is the patient's position? Are they sitting up like this gentleman with their shoulders hunched over? Are you hearing noises, rattling, wheezing? Look at their diaphragm. Are they really using the diaphragm and the intercostal muscles? So again, I think this slide just demonstrates, and this is right out of your book. You look at your patient. How hard are they working to breathe? Are they choking? Are they gagging? Are they anxious? Or they need to sit up? And if a patient can't breathe good, he's not going to let you lay them down until they're probably unconscious. Anybody have any questions on the assessment? Did I miss anything, Jeff?
She's just going through her.
Okay, next slide, 11. And for those who
I'm sorry, I was on mute.
Oh, I'm sorry.
No, that's okay. These are the vital signs, so you want to start memorizing them. These are what Becky was referring to a minute ago. So, anyway.
So the adults can be anywhere from 12 to 20. Rate. A child could be anywhere from 15 to 20 respirations per minute. And then an infant, those little things breathe fast, so they're going to be anywhere from 20 to 25. But if you have a rate, remember we talked about tachypnea and bradypnea. If you have a rate of respiration 8 or below or greater than 30, that is a very ominous sign, and you need to be prepared because that patient is going to have to probably have some assistant ventilation from you. Those patients will typically go into respiratory arrest because they're already just barely breathing. The pulse ox is a great tool. It's going to tell us what their oxygen levels are, and they should be anywhere as close to 100 as you can get them. Anything below 91, I will always give oxygen, but I'll be honest with you. Again, to me, this falls, treat your patient. Don't treat a number. And but it's a guide, and so once you get that baseline pulse O2 levels done, you'll be able to see if your patient's going to decompensate because you're going to start seeing their oxygen levels go down. You're also a nice little tool is it can get you your pulse rate, but never let that number on the pulse ox tell you, and that's a different lecture I think about your patient's pulse. You should always feel their pulse. You should listen to their apical heart rate, or you should at least feel their pulse. You might get the rate, but you also need a lot more about pulse that you need to have. You need to have a better understanding of besides just a number. Anything that I've missed there, Jeff?
I think you got it.
Okay, next one, assessment.
Okay.
Now, I don't know if we're going to have a lot of time to do this, but what I thought I would do, we're not going to have time to really talk about oscillation of the lung sound because I actually took all those slides out, but it's something that you can, Jeff, I have a video to insert here.
Can you click it?
Yeah, tap on it.
Okay.
For me, it says insert link.
Yep.
It says open link, and then it says open in Safari. And I think it's about 4 minutes. So I don't know if we are going to have chance to look at it all.
The first step that Zach would take
But
is
if you
initiating
guys
his standard
want to go
precautions. He
back
has his
on the
gloves
video
on, and he would
recording,
obtain
or at
permission
least
from the
take
victim, in this case
this
Sabrina.
link
He would warm up his
and
stethoscope,
look at it and maybe
and then
take
start
some
on the
time.
right
I mean, you can
front
find
look,
these
in the
links
right
all
front
over
side,
YouTube
the
and the
anterior side.
OECD.
He'll place the stethoscope on the right side of the anterior chest, 1 to 1.5 inches below the middle of the clavicle.
Jeff, can you hear me?
Listen to the upper left anterior lobe on the left side of the chest, 1 to 1.5 inches below the middle of the clavicle. Then the right lower lobe, placing the stethoscope on the right side of the chest, 2 inches below the nipple line.
What happened here?
And then the left anterior lobe, placing the stethoscope on the left side, 2 inches below the nipple line. We're going to listen to the back, starting in the right posterior lobe, placing the stethoscope on the upper right back between the top of the scapula and the spine, 2 inches below the neck. Then moving to the left upper lobe, posterior, same position, left upper back between the top of the scapula and the spine, 2 inches below the neck.
I can't get in.
Placing the stethoscope on the right lower back between the below the bottom of the scapula.
How do I chat him?
And then moving on to the left lower lobe, placing the stethoscope on the left lower back below the bottom of the scapula. After listening to all the lung fields, anterior and posterior, you verbalize what breath sounds you heard. At the OEC level, you should be noting if they are normal or abnormal. Abnormal breath sounds may be diminished, absent, noises such as crackles, wheezes, or gurgles, or unequal between right and left.
Okay.
Yeah. Jeff, can you hear me?
Yep, I can now. I just have to put my microphone next to the speaker.
Okay, you might want to go ahead and stop it. This is something, because we're already at pretty much a lot of time here.
Okay.
And I'm trying to get back to where I was on slides.
Management?
Let me pull them back up. Okay. So under management, okay, first of all, you're going to determine if your patient is choking. Can they speak to you? Can they speak in full sentences? You're going to probably, are they conscious? What is their level of consciousness? Are they alert? Is their consciousness diminished? They may be sitting straight up, and you may need to put them in a high Fowler's position, or they may be sitting in a tripod. Again, you're going to ask them to sample signs, symptoms, allergy, medications. Those are acronyms that you really need to continue to learn and continue to practice. Oxygen, we're not going to cover in this chapter. That's going to be a later chapter. And you just saw a brief film, and again, go back onto OEC and different YouTube sites, and you'll get some good. But I think what is important when you're listening to lung sounds, I know many of you guys can differentiate between wheezing and stridor and rails and different sounds, but for the OEC, again, I think what's really important is not getting lost in trying to give that breath sound a name, but it's recognizing that that breath sound is not normal. So again, under chapter summary, again, they're the most frequent emergencies that we're going to see and need to be prepared and immediately begin to respond to your patient that's in respiratory arrest or in having respiratory difficulties. So Jeff will go down. Anybody questions on respiratory emergencies or any add-ons that someone would like to bring forth that maybe was missed?
Oh. I have a question.
Okay.
What would the treatment be for any respiratory emergency?
Oxygen.
And?
No. Emergency.
3 things. You'll repeat it for almost every scenario. So high flow O2, treat for shock, rapid handoff to EMS.
Very good.
That's about all that we were permitted to do.
And again, all of that, the airway delivery, et cetera, is going to be covered in a different chapter. Okay, now we're going to start chapter 14, allergies and anaphylaxis. You right? Hold on, just 1 second. Okay. So in this
I'm on
chapter,
objectives.
Again, just take a look at your objectives and make sure that as you read this chapter 14 that you can define the following terms. What is anaphylaxis, hypersensitivity? Understand how an antigen may enter the body and the 4 sources. Understanding what an anaphylactic reaction is and how to use an EpiPen. Now, I'm not going to go, I'll show pictures of an EpiPen today, but this weekend I know that you're going to get excellent training on the mountain, on EpiPens, and how to use any of the auto injectors that may be carried. Now, immune system, I think we all know the immune system just protects our body from foreign substances by helping our body develop antibodies, okay? It's a very complex and a very difficult system, I think, one of the most difficult ones to have a really grasp of. But kind of put it in a nutshell here, no pun intended. When a foreign substance enters the body, it triggers or activates white blood cells all over your body. But then that simple first trigger really activates many other pathways and releases many other substances within our body that are going to help attack that foreign substance. Over time, it really does, the initial attack doesn't kill the antigen by itself, but with other cells that our bodies release, mast cells, white blood cells, hormones, and they're all coming from our bone marrow, our thymus, or our spleen, they can kill it or at least create antibodies so that if we're exposed to it again, then we should not have a reaction. And I think the most, when I think of our immune system, I think the best way to look at it is it's very complex, very difficult to understand, and we really don't need to understand it all, but we need to recognize it. But if you look at many of the new cancer drugs that are being used in the treatment of cancer now, they're all being directed by our immune system. So they're activating our body's own immune system to fight the cancer cells. Very interesting. So I'm not going to go over too much again on the anatomy and the physiology of it, but an antibody-antigen reaction, there's different cells that again will attack the offending foreign body or antigen, which helps destroy it. Now, an allergic reaction is an acquired, abnormal overreaction by our own immune system to otherwise harmful substance. And I think acquired is a key word in that sentence, only because we've all known people who have eaten corn tortillas their entire life. But the last corn tortilla absolutely causes an abnormal allergic reaction for whatever reason. So many of these reactions are acquired over time. Now, common causes of allergies and anaphylaxis: foods, peanuts, so kitty corral up at the mountain, we have to be aware of that. Those children, they do a superb job in preventing exposure, but sometimes it can happen in the cafeteria. Maybe they've had shellfish, There's a lot of environmental elements. So there's a plant on the mountain, some kind of thistle. I never remember what it is, but pollen, cedar, big up in and around the mountain area. So there's a lot of causative agents up in the mountains that we don't think about when we're up skiing in the cold. Again, some more common causes, medications. Patients will come in and maybe have an allergic reaction. Well, I've taken this forever. It's never done it before. Again, they've acquired an allergy to it. Chemicals. We don't use latex gloves, I don't believe, but that's a pretty good example. Blood transfusions. I mean, if you happen to have somebody that had one within the last 2 weeks, you might see it. So again, here, almost any substance can trigger an allergic reaction. And it can be most unexpected in most people. Again, it's regardless of their age and regardless of what their prior exposure has been to it. I had a friend who had a severe shellfish allergy, and this tells you, years ago they didn't even carry EpiPens. But an onion ring that was in a garnishment on a steak had been cooked on the same, in the same grease, I think, as shellfish. Well, she almost died before she got to the hospital. She never ate the onion ring. She just put it in her mouth. And so that can give you how quick, just an example of how quickly things like that can occur. So there's various degrees of allergic reactions. Your mild allergic reaction, I think we've probably all experienced that. All of a sudden we've got a kind of what I call the snotty nose, and it may, you know, take days, hours, or minutes to develop, but it usually will go away over time and with treatment, Benadryl or whatever it is that you may take, some of your newer agents. So a mild allergic reaction, itching, pruritus, flushed skin, hives or rash called urticaria, nasal congestion, tingling in and around the mouth. Slide 26, I'm sorry, Jeff, I'm just running on. Moderate allergic reaction. Again, as you read the chapter, take note of some of the key differential factors between a mild to a moderate to a severe type of allergic reaction. And I think when you have a patient where your thought process leading this could be an allergic reaction, one of the most important skills you'll need to keep in mind is ongoing assessment. That is, you're going to monitor that patient. And because those patients can move quickly from a mild reaction into a severe, maybe anaphylaxis. And then many of y'all in the medical field, if you've ever seen an anaphylactic reaction, you don't forget it. Slide 27, moderate, again, disappears over time, can increase in severity, but depending on a lot of different factors. A moderate allergic reaction, those patients may be getting a little like, oh, maybe a little bit of confusion, a little anxious. They might feel a little bit of tightening in their throats and wheezing, rash, hives, and sometimes that wheezing, usually that wheezing is something you can hear. You don't even need your stethoscope to hear it. So slide 29. Then signs and symptoms. If they have a persistent itch, maybe angioedema, maybe around their eyes and their lips, they're beginning to swell. When they start having a little abdominal pain and cramping, that's usually a sign that maybe this is could be progressing, a little bit more severe allergic reaction. And you might begin to see an elevation of their pulse rate, maybe their blood pressure, respiratory rate. All of those increases in vital signs are just the way of the body saying, I need to compensate for something going wrong inside of my body. So I'm going to have to work a little bit harder to keep this body functioning. Again, ongoing assessment. Okay, this is just a picture of a gentleman. He looks awful, but they're calling this a moderate allergic reaction. If I saw that patient, I'd be getting really nervous, and I would know that I'm not going to leave his side, and I'm going to probably stand right there, and I'm going to monitor him, probably go ahead and give him a little O2. Now, severe allergic reaction is just nothing more than a massive inflammatory response in the respiratory, every body system due to histamine release. And that's, again, another chemical that our body releases in the attempt to fight off that foreign body. And usually a severe allergic reaction can be almost immediate. And I think many in the medical field probably have seen these. And so, again, if you have a severe allergic reaction, you better be making your assessments fast and be making treatment decisions and get transport, oxygen, everything in line to get that patient somewhere where he can be treated in the hospital. Again, these patients with severe allergic reactions, they'll tell you, you'll see their anxiety, and they will often even voice the fact that, oh my gosh, I feel like I might die here. But then you'll also begin to see a decreased level of responsiveness, respiratory distress, severe angioedema. Their lung sounds will become abnormal because the fluid buildup in their lungs, and because of the swelling in their throats, they won't be able to swallow. And it's probably going to begin to see a decrease in their blood pressure. So again, if you have a patient with allergic reaction, it is imperative that you monitor and be prepared for progression of that allergic reaction, and hopefully you'll never see it. If the allergic reaction is taking place, maybe the offending agent is close by, maybe you need to move that patient safely to get them out of the bushes or whatever it is that they may be having a response to. Severity of allergic reaction determines timing. So there's a lot of factors you have to come into play before you move that patient. But again, allergic reactions, if that is your first thought and that's what you're seeing, you cannot stress enough the importance of assessing that patient every 5 minutes, looking at them, looking at their skin color, their face, their swelling, breathing. And then extended questioning at this point. You would have already hopefully gotten the sample done and included in that sample, because the patients who know that they have most of these patients are going to carry rescue packages. They're going to carry EpiPens. So you need to know that as soon as possible, because you may have to assist them in using it. Again, allergic reactions, I think the assessment really is just like any patient. A, B, C, D. Airway, breathing, circulation, disability. Try to identify what it is that may be causing it. If you can all possible, remove that patient. Monitor and check vital signs frequently. They can decompensate on you frequently.
Becky?
And go ahead, Jeff.
I think we skipped a slide. I'm on 35, but we have the AAA approach on 34.
Oh, did I? Oh, sure did. Thank you, Jeff. So
sure.
The AAA approach. Test question, preventing allergic reactions. Awareness. Awareness of one's known allergies and what triggers them. And obviously, some of these are common sense. Avoid it. If at all costs you want to avoid whatever it is that causes you to have the allergy. And action. And that's an understanding of what you need to do if the patient has an allergic reaction. Don't ever hesitate to call for transport and assistance, because these patients can decompensate very quickly. Jeff, we're going to go to 38. Now, epinephrine is the drug of choice, and again, I think this weekend you're going to get a good presentation on EpiPens and epinephrine, so we're not going to spend a lot of time there unless you tell me otherwise, Jeff. Most people who have severe allergies will have EpiPens with them. And again, EpiPen is a prescription. That's not something that they can buy. And never borrow EpiPens, and you're always going to check your labels as you would with any medication. Make sure it belongs to them and what the expiration date was.
If I could add one thing, when you work with the trainer on Saturday, verify that it's actually a trainer. I stabbed myself with the real thing. Maybe it was 2 years ago now, and it was a really bad day. But it was not my fault. The company was supposed to send me a trainer, and they sent me a real EpiPen.
Wow, yeah. That was about $600. Count your blessings. Okay. So these are just a couple of slides on EpiPens. And again, once again, guys, I can't tell you enough. Utilize YouTube and utilize the OEC channels, NSP sites to find videos on the actual administration of these. So again, we know what an allergy is, the body's overreaction. Most people don't know they have an allergy till they suffer from it, and they're even surprised by it. Tongue swelling, and Tracy brought up a good point in the picture of that little kid. In a child or a young child or infant, their little tongues are big anyway, so if that starts swelling up, that's a very bad sign regardless of adult or child, but it can quickly include an airway before you know what's happened there. Okay, and again, chapters AAA approach, awareness, avoidance, and action. Next question. So Jeff, I need to switch slides. Anybody have any questions on 14? Okay, Jeff, I need to go to 15, Jeff. Okay, Jeff, are you on chapter 15? Oh, okay. Oh, Vann's watching you. I'm sorry. Are we there? Are you there, Jeff? Okay, chapter 15, cardiovascular emergencies. Okay.
Oh, sorry, I was on mute. You're ready to go.
Okay. Okay, chapter 15, cardiovascular emergencies. Again, I'll reiterate, every chapter will have test questions from them, anywhere from 2 to 3 or more. So you're going to have to make sure you have read these chapters and know them. And chapter 15 in a nutshell. Know the various cardiac conditions, signs and symptoms. Here again, assessment, the OP, QRST, and the sample and management. ABCDs, you're going to treat for shock, high flow O2, rapid transport, and handoff to EMS. That is really cardiovascular in a nutshell. That tells you.
Deja vu.
Pardon?
Deja vu.
So the cardiovascular system. Again, we see the lungs encased in this is the pleural cavities. We see the alveoli. Just look at how the systems are all interchanged there. This is the blood flow. There is a good video about blood flow. Again, understanding the basic anatomy of the heart, the right, left atrium, right atrium. The heart, too, like the lungs, are enclosed in a sac called the pericardial sac, and we'll talk a little bit about that covers the musculature of the heart itself. So I'm not going to go into blood flow, but
I have one thing to point out for the test. It's a question that everybody misses. So remember that arteries take blood away from the heart. Veins take blood to the heart. And not all arteries are red and not all veins are blue. Do you know which ones are opposite? So the pulmonary vein is going to be, the pulmonary vein is going to be red because it's bringing blood back to the heart, but from the lungs where it's already picked up the O2. and the pulmonary artery is going to take blood from the heart to the lungs, and it's the exhausted blood, so it's going to be blue. But I've seen that on almost every test, so it's just one to think about it and, try to set it in your mind for the exam.
Okay, slide number 5, common causes of cardiovascular emergency. Most causes of the CV system failure are due to cardiovascular disease, which we all know is the leading cause of death worldwide. And cardiovascular disease can be caused by either coronary artery disease or atherosclerosis of the heart. Does anybody not know what atherosclerosis is? Okay, we're going to just talk a little bit. Hypertension. Now, hypertension here is shown as 140/90, and we know that untreated hypertension damages all of the blood vessels over time and probably affects 95% of us on the ski patrol. And if it's untreated, it will lead to stroke and kidney failure. Now, there are times when the data on this is somewhat conflicting, but there are patients that may have an increase in their blood pressure when they get into altitude. So again, it goes back to assessment, asking your patients if they had a history of hypertension. What, Ms. Allen? Next one we see a lot is congestive heart failure, and you think, really? Why would we see congestive heart failure on the mountain? But again, I think people who come to the mountain who have cardiovascular disease sometimes do not appreciate what altitude and the change in the oxygen can actually do to their bodies. There's been many times they've been called to the top of the gondola, a person who has some known cardiovascular disease that gets to the top of the mountain and all of a sudden begins to have a little pain, they can't breathe, and you have to just get them down from the altitude. Mm-hmm. This particular slide, Jeff, which is slide number 7, the lady with the blue feet, that's called pedal edema. And that will be part of your assessment when you're looking at a patient. And then the right side picture is just an x-ray of fluid in the lungs. Pulmonary edema, which can be caused or exacerbated at altitude, but also can be caused by altitude in just normal people. And that's a different chapter as well. So again, congestive heart failure, if patients have it, although they may be treated, if they get to altitude, they may run into a trouble there. Slide number 8. So
what makes your feet swell when you have congestive heart failure?
Anybody can answer that?
Your pumps don't work right. Your heart can't pump to promote the fluid balance in your body.
It usually comes from the right side, and it's a failure of your heart to draw blood back out of your tissues, so fluid builds up in your extremities.
Yeah, it's dependent. The feet are dependent, so it tends to go from the intercellular space to the extracellular space. But patients can have left-sided heart failure as well as right-sided heart failure. But I think the picture here is important when you're checking the patient and doing the assessment, looking at their feet for any swelling or any lung.
Would your blood pressure go up also? I mean, it seems like it's putting a lot of pressure on the body.
Yeah, it would.
If it's pumping it full on one side, not drawing it down on the other.
Will your blood pressure go up?
Yeah, potentially could.
Yeah, it does. And some of these patients actually have high blood pressure because their body's having to compensate to try to push blood. But there's a lot of questions whether or not altitude increases the blood pressure. Some would say yes, and some will say no. But I think at best it may be a moderate increase in the blood pressure. But these patients are probably on multiple medications or probably on medications for to augment the contractility of the heart, to decrease the swelling that you see in the feet and in the lungs. So, it's just I guess to me the point of this slide is it's a pump problem. The heart pump is a problem. And the problem can be in the heart itself, or it can also be in the lungs, or it can both be both lungs and heart pump, which is a cor pulmonale, which is another problem. But the real issue here is we have patients come on this mountain who have known cardiovascular disease, may be treated for mild congestive heart failure, but when they get in the altitude, their body may say, you're going to have to do something different here. We've seen, and Tracy and Jeff probably can testify to the fact they've been called to the mountain, top of the mountain, to get them down. And you might think they're having a heart attack, which brings up this next slide. Here you have distinguishing angina from myocardial infarction. Now you can go through this whole list of location of discomfort versus angina versus myocardial infarction. But when I look at this slide, these are all things that you have to understand and you have to know. But the real point to me this is, as an OEC provider, it is not our job to diagnose. Our job is to recognize immediately we have a cardiac issue here that's going to require high flow. Oxygen is going to have to tread immediate transport off that mountain and into a facility where they can be treated way beyond what we're going to give them. So you can go through there and you can look at all these different things, but what's important is you don't have to differentiate, but you just have to recognize the fact you have a cardiac emergency here. I need to get this patient transported off this mountain, treated. What we can do and get them to a hospital. Sudden cardiac arrest. I've never seen it, thank God. Maybe Jeff or Tracy have. But again, this slide just kind of brings home to me that if you have a patient that you think it's going to be it's a cardiac issue, you better call for the defibrillator. You better have it ready and you better have it handy. So when you make that call for help, keep this slide in your head. For every minute you delay getting that patient into defibrillation, their survival rates decrease significantly. Now, sudden cardiac arrest is exactly what it says it is. It is a sudden cardiac arrest. The heart just stops. No warning, no anything. These patients will just drop like a rag. There's lots of causes. It could be ventricular fibrillation. It could be something pulseless ventricular tachycardia. Asystole means the heart's not beating. But when you have ventricular fib or you have ventricular tachycardia, the heart's beating, but it's not beating adequately enough to pump blood out of the heart. So these patients will die if you don't get the defibrillator. And asystole is usually pretty end. Other causes, thromboembolism. I think we've all heard of blood clots, deep vein thrombosis, pulmonary embolysis. You know, we have pregnant women come to the mountain. We have patients with cardiovascular disease predisposed to DVTs and may be treated. We have patients who fracture their femur, fractures their pelvis. Those patients are at a higher risk of having a thromboembolism. Your big bones like your pelvis and your femur, you could have a fat emboli from just breaking those. So you have to keep those things in mind. And we all know that once an embolism breaks loose, it depending upon where it goes and that clot goes in your body as to actually what happens. But typically if it goes to the lung, those patients are probably not going to make it. Pericarditis and pericardial tamponade. Now, I've never seen pericarditis on the mountain, but pericardial tamponade is something that has to stay in the recesses of your mind. Because if you have a patient who has severe blunt trauma to the chest area, do you remember that sac around the heart that I told you about, the pericardial sac? Well, if that gets inflamed or infected, then they have an infection called pericarditis. Now, in pericardial tamponade, let's say they have blunt force trauma, they get hit a tree with their chest direct on, or even a kid playing baseball hits them right in the chest. It can cause a fluid buildup in that pericardial space, and it is life-threatening. And there's other signs and symptoms that you can look for too, and I'm not going to get into that here, but that fluid begins to build up around the heart, so it works as kind of like a swelling of the heart, the shield around the heart, so the heart gets pressure from the fluid buildup, so therefore it can't beat adequately. And sometimes when you're monitoring blood pressures, that's probably not beyond what we can talk about here, what we should talk about, but there's a difference in blood pressure readings that you can start to see. But if you have a patient that gets hit in the chest, this is definitely a concern because it is life-threatening and it requires, again, immediate transport, get them off the mountain so they can get that fluid removed. Aortic aneurysm. Anybody have a question or would like to offer a comment? Because I've got so many more slides. I'm so sorry. Aortic aneurysm, that's just where a wall in the aorta, somewhere along in the aorta, becomes weak. It's like a ballooning out of the aorta, and it can rupture. I had a friend of mine readjust of this very thing. He just died. And a dissection, that's when the wall within the aorta begins to tear away. Usually they'll have severe chest pain. Just take a peek, look at this, and understand what it is. Again, I want to emphasize it's not our job to diagnose, but it's our job to recognize and immediately transport and treat that patient. Now, an aneurysm, most old people, we all probably as we age are going to get an aortic aneurysm. And the degree of aneurysm is how they decide how they're going to treat it. But if so happened you were doing an abdominal assessment, you felt this pulsating bulge, which thank God I never have, in a patient's abdomen, that may be your first sign that there may be a massive aneurysm in there. Again, you get them off the mountain as quickly as possible. So I keep talking about getting the management of these cardiac patients. It's called the chain of survival. You want immediate recognition of cardiac arrest or cardiac issues that concern you enough. You're going to activate EMS. You're going to call for transport. You're going to be able to provide quality CPR. I think that's your Saturday discussion as well. You're going to have a defibrillator prepared, ready, and available, and you're going to use it if you need it. And you're going to early, effective, advanced life support. And then the last little red circle is the integrated post-cardiac care. Again, this is all about getting those patients to care very quickly. So, again, in your assessment, you might look for, patients that have pacemakers under their skin, and I think there's a discussion about that during your CPR class. Again, it's immediate transport, high-flow oxygen therapy. The patient may have a known angina, and they may carry nitroglycerin. We cannot give it to them, but we can assist the patient, and they can take it up to 3 times.
Your blood pressure.
Aspirin. Pardon? Again, these are things you need to read in your book and have a clear understanding. And I think you're going to talk about it again in your CPR class. And aspirin. You can assist the patient. We cannot give them any medications whatsoever, but if they carry aspirin, you can certainly give them. You can assist them in taking aspirin, and hopefully they'll know whether or not they're allergic to aspirin products. Okay. Final slide. Assessment. This is regardless. Thing safety, ABCD, O2 sample. You have to get it from family members. OPQRST to determine the quality, the pain, where it's located, and you're going to monitor all your vital signs frequently, anywhere from 3 to 5 minutes or at least every 5 minutes. These patients can decompensate on you quickly. Any questions? Okay, Jeff, we're going to go to 16. We're almost done. And I think we're actually maybe going to be on schedule. Okay. The chapter 16 is going to be over gastrointestinal and GU emergencies. Okay, I think Jeff's got our slides up. We'll go through this one very quickly again. Pay attention to the objectives in each one of your chapters and know them. We're going to try to talk about 6 causes of gastrointestinal and GU systems, signs and symptoms of emergency involving the GI tract and GU systems, and we're going to compare and contrast visceral pain and parietal pain. And we'll discuss that and why those two, understanding those two terms right there are going to be very important. Slide number 3, again, the objectives. Pay attention to them, understand them, and know them. You will see them on a lot of these put into test question forms. We'll go to topics, a little bit anatomy and physiology, the acute abdomen, which I think is one of the key topics that we're going to probably go over. Slide number 5. The abdomen and the pelvis contain hollow organs and solid organs. Can anybody tell me why that makes a difference?
Hollow organs sound funny when you pound on them.
Well, okay. I'm not going to all the different organs in the body because I didn't list them all, but it depends on. Solid organs are probably more blood supply, so if you have trauma to the abdomen and the pelvis, you can damage either some of the hollow organs. What's a hollow organ? Real quick. Bladder. But a bladder, if it's full, it's kind of solid, and then I don't think that organ is solid. And then solid organ.
Spleen.
Spleen. Kidneys.
Brain.
Pardon?
Brain.
Yeah, a little different end, but.
Well, those, yeah, but that's not in it's not in my stomach. I could comment on something, but I won't. So again, this is just a picture. I don't particularly like it, but like neck pain in your liver, spleen in your shoulder. The one thing I will say is if you look at the gallbladder, if you have patients that have pain right in their mid-sternum area, right in that epigastric area of the abdomen, sometimes that can be gallbladder, it could be pancreatitis. We have the appendix down there. We have the kidneys, we have the ureters, we have the bladder. So those are all organs and things that can be damaged during the course of a great fall or on the mountain. The acute abdomen. Now, I think that's a very important term for 2 things. First of all, I think you have to be able to recognize an acute abdomen because that is a serious emergency there. Again, what are causes? We've all known people, appendicitis, pancreatitis, hurts like the devil, hepatitis, cholecystitis, gallbladder problems, pyelonephritis, kidney infection, lithiasis. Okay, lithiasis. So these are all causes of acute abdomen. Again, I think I'm on slide 8.
Yep.
Other causes can be bowel obstruction, perforated bowel. That could happen in a good fall on the mountain. They could already have peptic ulcer disease, esophagitis, gastrointestinal bleeding. Heavy drinkers will have a lot of that. And then they could have OB-GYN-related conditions. I think it was Jeff who actually responded to a young female patient. He recognized, and it ended up being an ectopic pregnancy. So the pain that, Jeff, was it you? I can't remember, but somebody did.
Yep.
They answered a call on the mountain, and the woman was of age that she could be pregnant. And with the right sample history, taking the history, Jeff was able to determine there was a chance she was pregnant, and sure enough, she had an ectopic pregnancy, which means her pregnancy implanted in one of the fallopian tubes. And as that pregnancy begins to grow, what will happen, it will rupture, and that can be a very life-threatening issue there. So,
yeah, the key was in sample. I got down to, well, how old are you? You know, obviously you could tell she's female, but she was, I think, 16. And I said, do you take any medications? And she said, well, I used to take birth control, but I haven't taken it for 3 months. And that's when it kind of started turning.
Yeah.
So
again, gastrointestinal ailments, oh my goodness, people come to the mountain sick. Gastroenteritis, nausea, vomiting, colic, diarrhea. You're going to see all of this on the mountain. And those patients just need to go home as quickly as possible. But I think, again, this is just another list of causes. Cystitis, bladder infection, food poisoning from staph or salmonella, giardia. Slide number 11, again, assessment. It falls back on ABCDs. You're going to determine what's wrong with the patient. You're going to complete your sample, and you're going to do the OPQRST. You're going to do a physical exam and an abdominal palpation. And I actually have a video on abdominal palpation, but I don't think we're going to have time to actually do it. So when you come back and you look at this if you want to, or you can go online, and there's some very good videos out there that go over the quadrants in the abdomen and how to do the assessment there. But again, this is where the video is, but I'm not going to open the video because.
Really? I don't see it.
You know, this one was a little weird how I had to do it. Insert link. So I'm not going to do it, but it's in there.
Okay.
But that's something you can practice when you go up to the mountain, is in your book, or find a video and how to divide the abdomen into quadrants and how to begin your assessment. For example, if a patient has right lower quadrant pain, you're going to begin your assessment in the opposite side of the complaint of pain. So again, just go over it in your book, find a video, and go over it in the video as well. And again, we're not diagnosticians. We're not here to make these diagnoses and differentiate between. I think most of us probably would recognize appendicitis, but again, it's kind of like a cardiac emergency. If you see something very acute and painful in that abdomen, that in itself is a medical emergency and should be handled as such, and that is to get that patient off the mountain, whether they go on their own accord or whether they go down into transport. And you're going to do a very in-depth physical examination. Patients are going to tell you how where they're going to want to, how their position they're going to be at in the bed or on the gurney. And most of the time, they're going to want their knees slightly bent, taking the pressure off the abdomen. Like any acute illness or emergency, you're going to take their vital signs, their blood pressure, their pulse, their respirations, and you're going to monitor them frequently. And you don't give them anything by mouth. It's kind of the rule of thumb. If you have a patient on the mountain, you're going to send down either by ambulance, you're going to suggest that patient go to the hospital. The best thing you can do is say, don't take anything by mouth, because you don't know what the outcome or the management's going to be on that patient. So again, just say, no, it's best you don't take anything till you go see the physician in the emergency room. Did I miss anything?
I think that's it. Yeah.
Recognize those patients that have an acute abdomen. You don't have to worry about trying to make a diagnosis. Keep the differential in your head of the various illnesses, problems that it could be. But again, recognize the fact that you have an acute abdomen. Maybe it's swelling, maybe it's extremely painful. And again, we can do what we can do, and that's just oxygen and get them out of the mountain as quickly into definitive care. Again, go back, review your anatomy and physiology so you have a very good understanding of what structures lie within the abdominal cavity. So if a patient has a major fall or collision on the mountain, you can look at that gut and go, okay, what am I could look? Maybe they hit their kidneys, maybe they've ruptured a kidney, maybe they've ruptured their bladder, maybe they've perforated their gut. So you keep all of these things in the back of the recesses of your mind, but you don't have to be able to pinpoint each one. You just have to know that it's, and this cartoon says it all. Now that I've told you about the food, would you like to see the pictures? Oh, nice, but I think we have enough information to see. We need to get you to a hospital. So I think that's going to end it. So Vann can start hers. Any questions?
You said something about visceral pain earlier.
Oh, yeah.
Oh, my God. I totally.
That's an important test question, too.
Yeah, it is, and I just totally, let me see where Okay.
I think while you're looking it up, the main thing that is going to be on the test and feedback, the main thing that you're going to get questioned on that is how do you tell the difference? And so visceral, just think all over, and parietal, think it's the type of pain that you could point to it.
Okay.
Right. And it has to do with the access to the nerves. Parietal is it's localized. The patient will be able to put their finger right on it, and if they can't say, "Oh my gosh, I don't know where it hurts," then you have visceral pain because they can't demonstrate. Pretty diffuse. Thank you, Jeff. I'm sorry I missed that.
There's a more technical explanation for it, but I think that's all you need to know.
Yeah. Any other questions? Okay, I'm going to turn it over to Vann. I guess it's potty break time for a minute. So Vann can get
if anyone needs to take a quick break, take it now, and then we'll get the slides switched over and be back in 5 minutes. Huh, okay. So now,
Okay.
Vann, I think you're the presenter.
What can I do to help you?
Okay. Can you hear me, Jeff?
Yep.
Okay. I just wanted to make sure my microphone was working, and then I'm just going to test real quick. Can you see my desktop?
I see Google.
Okay, so I'm having the same issue because I still don't see what you're talking about. I know. I don't see this arrow that you're talking about. Because when I go to my menu and I go to my settings, I'm screen sharing. So I'm going to turn it off, and I'm going to turn it back on.
Do you want to start? Whoops.
Jeff, should everybody be able to share their screen? So, like, should I see the arrow?
I think I'm seeing Becky's webcam.
Yeah, you did.
That's really weird. Okay.
Okay. So she's still connected then?
No.
Let me come up.
Hang on, I'll get it. Oh, wait. Okay, so now I think I'm seeing your webcam.
Okay, I'm not the presenter anymore, so can you...
You're not?
No.
Uh-oh. Hang on. Okay, let me see. You know what was weird? When I first logged on, it let me share it let me choose to share my entire screen.
Mm-hmm.
Now it's only letting me it won't let me choose. But let's try it. Where are you? There you are. Make presenter.
Okay, I'm going to look for it. Okay, so I'm going to start sharing. I click start sharing, and it goes to this Google page. So
do you have a little icon like mine's in the upper left corner of the app?
I don't have any icons, no.
Give me one there.
There should be a way that you can choose what you share.
I'm looking under settings.
There's lightning over there.
There's lightning?
Mm-hmm.
Let's see. Resources.
Cool.
What now?
This could be like a nurse.
No.
People's lungs.
Account preferences.
And they'll say yellow jackets.
No, it should. Like mine is. I have a bar where it's got like the recording, the participants, all that.
Yes.
Do you see that? Do you see a camera? Looks like a video camera.
I see a camera. Yes.
Okay, then right next to that, there's an icon that lets you, I think, choose what you share.
Is it like 3
them off the mountain.
dots connected?
Try it.
Okay, so I click it and it says hide,
Okay.
pause, and stop.
Hide, pause, and start.
Stop.
We'll try. Oh, stop.
Mhm.
Boy, why won't it let you choose?
I don't know. I just don't understand why I can't.
Can you go to Google Drive and just present through Chrome?
Okay, I'll go to the drive. Yeah.
Or I mean, from Chrome.
Let me try.
You have like a Chrome window open with like, I don't know, it looks like a woman on it. Maybe it's a man.
She's an architect.
No. Yeah, see, that's what, I don't have that open. I don't know why it's showing.
Really?
No, I don't, but it's the same thing that my mom is seeing on hers. I just can't figure out why I can't share.
Why?
That person?
Yeah, it's really weird. It worked last week with Jason.
60-something. Young.
I mean, I could see what I can do. I mean, we gotta get the book, and obviously.
Yeah.
Well, I can do the same thing. I can run the slides.
I apologize. I don't know what to do, Jeff. I just don't know how to.
Okay. Oh, that's all right. We're working the kinks out.
Okay.
Let me open it. Oh, wait. I'll probably have to let me take control back. I could probably have you, if I sign out as the host and you sign back in.
Okay.
But I don't know. We might lose the whole thing.
I know.
So you have them in the lectures folder?
They're in the lectures folder, yes.
What's the first one? 20.
Chapter 25.
Or 25. Okay. Got it.
I actually have 5 chapters tonight.
Okay.
Yeah.
Fun.
Yeah. Some of them should be pretty quick.
So, is everybody seeing the slides now?
I see them.
Yep.
I don't.
Okay. Well, we'll try it this way.
Okay, I'm sorry. I wonder if you gave me
don't worry about it.
Yeah. I wanted to do it. I really did. I'm so sorry.
I'll be the film strip editor.
I know, just what you wanted to do.
Huh. I don't know how to make it play by itself, but that's okay. Well, I guess I'll just work the mouse.
Yeah, because see, when I open it, there's usually a play button at the top, so you can...
Yeah, I know. That's what I thought. I don't see it.
So strange.
Oh, present. There we go.
There we go.
Is that better?
Yes, that's better. I don't think I can, I still can't advance them, but at least we can see it in full screen.
I wish I could just give you control. Then you could control my monitor, but...
I know.
Oh, yeah, here. Allow control.
Okay.
I think you're in control now. So that'll mostly work.
Let me see.
I think just hit the space bar or click your mouse on it.
I'm on an iPad.
Oh, or tap it.
Okay,
No?
Let's see. No? I thought I did for a minute.
I wonder if you have to accept. Let me see. Oh, yeah, here. I'll try again. Are you sure you want Vann Bennett to have control of your computer?
Think hard, Jeff. Think hard.
So you should have it? No?
No.
All right. Plan B.
Okay, there we go. Am I doing that, though?
I did it. I clicked it for you,
okay.
yeah.
Are we ready? Is everybody here?
I don't know where it is. Where'd you put it, you know?
Down. It's down on the drawer.
Oh, in the drawer. Who's new?
Here, let's see. Let's take a quick roll call. I see Noelle, Eve, Kurt, Brian, Woody,
We just do a roll call.
Nick, Trace.
I heard my name.
Yeah, somebody was hungry, so they were going to go eat, I think.
Yeah, Tracy, when Trace gets on the mountain, you're going to have about as confusing a time as me and Jeff Roberts. I think that's everybody.
Okay. All right, perfect. Well, in the interest of time, we'll go ahead and get started. My name is Vann Bennett. I am just finished my first year on the patrol, and I'm a candidate instructor as well. So thanks for having me tonight. I'm going to cover 5 chapters this evening, and not to minimize any of them, but you'll see that some of them, I'm sure you'll be asking yourself, why are we even talking about this for the National Ski Patrol? But I'll hope to help you make sense of some of it, walk you through what I think you really should know or pay attention to for the test, and get out of here this evening, hopefully a little bit on time. So Chapter 25 is cold-related emergencies. So needless to say, as a ski patrol, our work environment is cold most of the time. At least we hope so, which means there's lots of snow and we're all having fun at the same time. So we're going to talk about most of the objectives that you see on the slide. I left all of them in there because I want you to understand that these are objectives that you need to know for the test. And I'll point out some things that I know for sure are in the test bank, and we can talk about those if we need to. So we're going to talk about the 4 mechanisms of heat loss. I'm going to ask for your help in defining those. We're going to talk about the signs and symptoms of cold exposure, talk about frostbite versus frost nip, and talk about hypothermia, how to assess it, how to treat it, or how to at least manage it and get people to the next level of care. So Jeff, you can just keep advancing through the objectives if you like. We're also going to define after drop, and then talk about, again, assessment and management of patients with a cold injury. Okay, next slide. You can just page through this one. We're not going to talk about the avalanche portion of it. I would encourage you to read it in the book. There's separate avalanche training that the Ski Patrol goes through, and I think you actually have to have at least a year under your belt before you do it. So I decided not to cover that tonight, just in the interest of time. So from an anatomy and physiology perspective, I want you to make sure that you understand the 4 mechanisms of heat loss. So from the reading that you have done, can somebody give me the definition of conduction? Okay, I'll do the first one. So conduction is the direct transfer of heat from a warm object to a colder object when both are in direct contact with one another. So if you are a warm body laying on a cold rock, your body heat is going to transfer to that colder rock, hence making you colder. Second mechanism of heat loss is convection. Does anybody know what convection is, or give me a brief definition? So
wind.
Yes, wind, okay. So it's direct transfer of heat through circulating air or fluid. So it could be air or water. So this can happen a lot on the mountain because we've obviously are in cold temperatures. It can also happen in cold water. Cold water can actually accelerate heat loss 25-fold. So the third mechanism is evaporation. And this is simply occurs, at least primarily in humans, through sweating. So our heat evaporates as our sweat evaporates off of our body. And that heat is transferred to the environment, thus decreasing our body temperature. And the last mechanism of heat loss is radiation. Any takers on that? Radiation? That's just the emission of infrared heat, so heat leaving our body. And that actually could possibly be a test question because radiation accounts for as much as 60% of the heat loss through our body. So as much as 60% of the heat loss through our body. So here's an example, just a kind of a graphic to help you better understand the 4 mechanisms of heat loss and gives you examples with a real-life person. So again, these are test questions. I know that 100%. So make sure that you understand these 4 mechanisms and how they work. So there are numerous factors that can contribute to cold injuries. One are freezing temperatures and high winds and high altitude. So those first 3 things we can experience at Ski Apache all in the same day. Use of drugs or alcohol is actually one of the largest contributors or predisposing factors to a cold injury, and we can also and do see that frequently at Ski Apache, both in the winter and in the summer. And if you've actually had a previous frostbite injury, you're already predisposed to another one. And then overexertion, which produces fatigue and sweat, so can result in a cold injury. So when people are skiing, even though it's cold outside, they can work up a sweat. So without the proper clothing or equipment, they can predispose themselves to a cold injury. Poor fitting, inadequate, or wet clothing. So Ski Apache is a ski area that's known for a lot of beginner skiers. So we see a lot of poor fitting, or more appropriately, I guess, inadequate clothing, people that are just unprepared for cold temperatures. I've seen people skiing without hats, people skiing without gloves, and come in and they are freezing. Or they fall a lot and they get soaking wet, and again, they're not dressed appropriately, so they can end up with a cold injury. Dehydration, due to the altitude, the fact that they are learning to ski or skiing very hard because they're already really good and not drinking enough water, is another factor that can contribute to cold injuries. Impaired circulation, so they may show up already with impaired circulation, and as a result of all these factors, predispose themselves to a cold injury. And poor nutrition. So a lot of this may sound like common sense, but people show up every day and all day with numerous factors that we've outlined on the slides. So here are some of the common cold-related emergencies that we might see. Frost nip is superficial, so there's no damage, but it is a cold injury that we could see and probably do see a lot. People come in and they're cold. Their hands, the ears, the tip of their nose, their fingers, or their toes, so extremities, small little extremities. They come into the first aid room and they are just freezing. Or if they've had to sit on the side of the mountain because they've had a serious injury, and they come to the patrol room and they've got frost nip on those smaller extremities. And then you've got frostbite, which it's an actual freezing of the body tissue, and it may only involve superficial tissues, but it may extend to deep tissues depending on the severity of it. I personally have never seen severe or even mild frostbites. It's mostly frost nip that I've seen, but be aware that it can occur, and we're going to take a look at some pictures and signs to look for. Another cold-related emergency is hypothermia, and hypothermia is you actually it's an abnormally low body temperature. So clinically, it's below 95 degrees Fahrenheit, according to the American Heart Association. So that's when your heat loss exceeds your metabolic heat production. So your body, although it will try to compensate, can't keep up, and your body temperature will actually drop. Secondary hypothermia is hypothermia due to a systemic disorder. So it's not necessarily the first thing, but it's associated with a traumatized or critically ill patient. It can still also be severe and life-threatening. And then what about after drop? Can anybody define after drop? I know it's kind of on the slide, but there's a better definition. So it's somewhat self-explanatory after drop. Your body temperature continues to drop even after you've kind of come in from the cold and maybe warming has already started, but that cold blood gets recirculated, so your body gets circulated back to the heart, and your core temperature can drop even further. So severe cases can result in shock and sometimes cardiac arrest. And then windburn, another common cold-related emergency that we'll see on the mountain, it's almost like a sunburn from the wind. It's irritation to the skin because you haven't had your face covered and it's been cold or windy outside. So I left this picture in here because, as I said, alcohol is one of the contributing factors to cold-related emergencies. And believe it or not, it's something that we have seen and see frequently on the mountain in the winter and in the summertime if you have occasion to work up there. So always a good thing to, through your sample, you'll ask questions about alcohol intake, and something to note if somebody is experiencing a cold-related emergency is whether or not they've had alcohol that day. This is probably a very accurate picture, and I can't tell you how many times you see people sitting either on the side of the hill or in a chair down at the bottom. Again, poor fitting equipment or clothing or lack of proper clothing. So part of our job as patrollers is to encourage people to be safe, and part of that is to have the right equipment. So you'll learn in our morning meetings, we're constantly being reminded to remind customers to wear sunblock, wear helmets. And so if you see someone on the side of the hill who doesn't have gloves on, it's a good idea to suggest that they go get a pair of gloves from the sports shop to help prevent something that could be potentially more serious. So things that you should look for as a patroller beyond just somebody who may have fallen, other things to kind of consider. Okay, next slide. So part of that, and I know Jamie talked about some of this in her first presentation, is we have to take care of ourselves. We don't want to be the victim. So we need to be prepared as patrollers every day and make sure that we are layered for work, because conditions can change rapidly. You can go from a sunny day to snowing and windy all in one day. So you have to be prepared and make sure that you're prepared to help someone if need be. Next slide. Kind of what I was referencing earlier is be attentive to yourself, but also anybody that you're skiing with or people that you might just happen to ride the lift up with. Make sure that you're letting them know anything that you might see that could put them at risk. At the same time, keep yourself dry, take care of yourself. That's okay, you can keep going, it's all right. So some of the things to avoid are tight or restrictive clothing and boots, and I'm sure if you guys have skied at all, your comfort is what you focus on, at least for me and my feet. But change your socks, keep them dry, and definitely while you're patrolling and in general while you're in cold conditions, avoid alcohol, caffeine, which I think is hilarious because I don't live without coffee, and then drugs, because all of these things can predispose you to cold injury. I should have just deleted caffeine. It's not even funny. And then don't tolerate any numbness in your feet or hands. So be aware and don't just think, oh, it'll get better. So the next few slides are just an idea of how you can prepare yourself as a patroller for cold weather rescue, and that's again in layers. So you have a base layer. Next slide shows, then you've got a jacket over that, and then the next slide shows you've got your patrol vest and your hat and your gloves and you're ready to go. So if you get hot, you can pare that down, but you're ready for all conditions. So part of the assessment when assessing any cold-related emergency obviously is scene safety. Again, Do not become a victim. Make sure that you're taking care of yourself relative to cold-related emergencies. And then assess the ABCDs and look for signs of cold injury. So frostbite, hypothermia, mild, moderate, or severe.
Yep.
Here's just a picture of something that you might see in the patrol room. You wouldn't probably see that on the side of the mountain because you're not going to take their boots off, but an example of what frostbite might look like. And then your assessment would include, obviously, a decaf bottle and sample assessment. And then potentially measuring their core body temperature. But as Becky had referenced earlier, listen to your patient. If they're shivering, if they tell you they're freezing, if they tell you something hurts or something is numb, they're the best person to give you that information.
As long as it's up here, can we run through decaf bottles and sample again?
Sure. So sample signs or symptoms. A is for allergies. So are you allergic to any medications, or are you allergic to any foods or insect or animals? M is medications, in that are you taking any medications currently, prescription or over-the-counter? P, what is the P? I'm forgetting the P right now.
Medical history?
That's right, pertinent medical history. So have you had any recent surgeries? Do you have a history of heart attack, or do you have a history of stroke? Anything that you think would be pertinent to your care today in the first aid room. L is your last oral intake. So if it's 3 o'clock in the afternoon, when's the last time you ate? What did you eat? Have you had any alcohol or any drugs today? Prescription or recreational? We're not the police. A lot of people don't want to answer that question, but we're not the police. We're only asking because we need to make sure we understand completely your condition when we care for you.
Hey, Vann.
And then event. Yes, ma'am.
This is Tracy. On the last intake, one thing I like to also ask is just kind of ins and outs without getting really personal, just to try to figure out if there's something, you find out that they've been constipated for 2 days or something.
Okay, yes.
So I like to kind of ask on the ins and the outs.
Okay, perfect. Thank you. And events. So the events leading up to either the injury or the illness, if you're trying to determine whether this is an illness or an injury. Okay, what about decaf bottles? Does anybody want to help me out with that? The acronym?
I'll start.
Okay.
Deformities.
Deformities.
Who's next? Contusions.
Contusions.
Somebody say it.
Abrasions.
Punctures.
Punctures. All right, what about the BTLS?
Bleeding or bruising.
Mm-hmm.
Tenderness.
Burns or bleeding or bruises. Okay.
Oh, yep.
Tenderness. Lacerations.
I thought that was lasers.
No, it'd be so cool if it was, though. It might be actually a really good question. There's all kinds of lasers you can have today. Lacerations and swelling.
There we go.
Yeah, so it's a really good thing that Jeff pointed those out, because I know daily, multiple times daily, you'll use a sample history. And once you get it down, you've got it. Decaf bottles, I guess depending on the situation, maybe less frequently than sample, but it's important nonetheless.
And you'll get it definitely, absolutely on the written test, and you may get decaf bottles on the practical. Like you may say, I don't see any decaf bottles, and the evaluator might say, that's interesting. What does the C stand for?
Yes.
So.
Yeah, so write those down, and I can follow up if you don't have it already and get that to you, but very important.
Practice daily.
Yes.
Oh.
No, that's okay. It's a good time.
Oh, okay.
A good time to move forward. So management of frost nip from a patroller perspective, seek shelter. So either they're going to come into the first aid room, or they will have been brought in and warm them up, warm the area that they say is cold. We've got water bottles that we can put warm water in. We've got blankets that we can heat up in the dryer, all kinds of ways to get them warmed up and feeling better.
We have a kid cooker.
The kid cooker. I've never heard it called that. I like it.
Really? Bag on the end. The kid in the bag. Kid cooker is a bag that's attached to a hairdryer, and you put the kid in the bag.
And you put the kid in the bag. That's right.
Yeah.
Gosh.
Usually try to leave the side of the bag. Works better.
I've never used it, but now I want to. Okay, and the management of frostbite is, again, to warm the area rapidly. And so just some factors to consider and things that you should definitely pay attention to in your book, because I think you guys are getting the test bank questions per chapter. So there are definitely questions about frostbites and warming the area and the factors to consider when warming a frostbitten body part. Okay, next slide. So,
Uh-oh.
That's
this one?
That one, there you go. It's just an example of one way that you could warm a frostbitten body part, and that's immersing the extremity in warm water. And the best time to do that is usually as soon as possible after you discover that it's frostbitten. And you know for sure it's not going to reach
Spanish Inquisition. It looks like the Spanish Inquisition.
It does look awful, right? Okay, I'm not sure what's going on with the slide deck there. You can go to the next slide, Jeff.
Sorry, my mouse is like suddenly really sensitive.
That's okay.
And if I bump it, there we go.
Okay, so management of hypothermia. The most important thing is to get them inside to prevent the loss of heat. So get them inside into a shelter. If they haven't walked in on their own, get them inside as quickly as you can and start warming them up as fast as you can, or as soon as you can. So if they've got wet clothing or cold clothing, replace it or take it off. Get that off of their body, and then again, warm them with high energy drinks or food. We've got hot chocolate. We've got hot water. We've got even hot coffee, something to get them to start warming up if they can tolerate it. If they're shivering, that's a primary passive warming method, so that's usually a good thing. Their body is fighting off that hypothermia themselves. Okay, go ahead. Next slide. And so for any patient that is not responding to warming and might have severe hypothermia, you're going to get them to a definitive care facility as fast as you possibly can, and that would be calling for transportation from the mountain. So if that's the case, hopefully that's something that we'll identify early. An ambulance to the area is 40 minutes up and 40 minutes down. So as soon as it's recognized that they're not responding, we'll get them on their way with transportation. Of course, monitor their vital signs and keep an eye on their circulation, specifically in their hands and feet. Could be a life-threatening situation if it is severe. Okay, so I'm not going to necessarily go through all of the chapter summary signs, but needless to say, we work in an outdoor environment, and cold-related emergencies can and do happen. So we need to pay attention and make sure that we're looking for those types of emergencies, and then we're educating customers when we have the opportunity on how to prevent that. Always remember that as a responder that you need to remember to take care of yourself in the outdoor environment so that you don't become a victim. So I'm just going to ask you one question and see if you guys get this. Which sign would you observe that's the earliest in a mildly hypothermic patient? What sign can you easily observe in a mildly hypothermic patient?
Shivering?
Shivering, yes, good. That is a test question. So again, you can go on to the next. Oh, okay, you did. Thank you. So one of the risks for hypothermia, as about earlier, is when patients have been injured on the hill and have had to spend an extra amount of time either waiting for rescue or because they had a complicated rescue. So once they're extricated in the first aid room, hypothermia has to be addressed, or at least look for signs. And just remember, they're not dead until they're warm and dead. So keep that in mind. We have lots of passive warming opportunities in the first aid room, and once you're actually there and you can get some hands-on experience with them, you'll see they're readily available and easy to use. Has anybody ever had hypothermia or had a family member that experienced it? Or no? That's good. That's good. Okay, and so just remember, I totally lost my train of thought. Sorry, I looked at the slide. Frostbite requires rapid warming, and so we have, once it's identified, we've got ways to do that in the patrol room. And once you're on site, you'll have a better understanding of what the local protocols are and how we can do that once they're in the first aid room.
Oh, I have something to add that's not in here.
Sure.
I'm pretty sure it's in the book. There's a note of caution when, and Tracy might be able to help me better, but when somebody has severe hypothermia, they're prone to, they're prone to experiencing a heart attack if they're moved suddenly. So we have to be careful with when we find a hypothermic patient on the slopes. You have to be extra careful with the sled ride, that they don't get jostled around and then they go into cardiac arrest.
They can go into defib.
Mm-hmm.
So we'd always say, very, very tender lifting and, careful moving around.
Okay, good to note. One last thing that I will note is, and we're going to talk about this in my last chapter, which is water emergencies. We do have a pond and a creek on site at the ski hill that sometimes I don't think they're frozen oftentimes, but it is a risk for cold-related emergencies in the event that somebody got into the pond, which would be rare because it's kind of out of the way. But the creek, sometimes, you could fall through the snow to the creek, or when the snow starts to melt and the creek is running, it's another risk for a cold-related emergency. So just something to be aware of, and you'll see them while you're at the mountain this weekend. Okay, and that's it for Chapter 25. Does anybody have any questions before we move on to 26?
Hey, Vann, this is Tracy,
yes.
And maybe this is more a question for Jeff, too, but do we not talk about the umbles anymore?
I don't know. I didn't see that anywhere in here.
You guys know what I'm talking about? And I don't want to add more complication, but it is an actual thing that you will see, and it's a sign. And so they would say somebody is, becoming hypothermic, they will start to have the umbles, so they will stumble, fumble, mumble, and it's just kind of watching their, their dexterity and just physical pieces and parts kind of lose function. So I didn't know if that was in OEC or not. I thought it was at some point, but it's kind of more just real world to pay attention to.
That's a great. I've never heard of that, so I think that's awesome. The umbles. Okay.
Yeah, I haven't heard it that way. I know that we do look. They're still there. That's actually the first time I've heard it as umbles.
Huh.
Yeah, me too.
I thought it was an OEC, but you guys would probably know because I'm maybe a step away. But grumbles, just change in behavior. They start to get negative, slower reaction time. So I've always heard it called the umbles. But
they're going toward medical terms now. So altered mental status and ataxia.
I like that.
That's awesome.
Easier, yeah.
Okay. All right. So chapter 26, we're going to go from cold-related to heat-related emergencies. And although most of our time on the mountain, again, is spent in the winter months, we do have occasion every now and then to work in the summer, if you like, and do something a little bit different. So and OEC is outdoor emergency care, so it's pretty comprehensive. So we're going to talk about how the body normally adjusts to a hot environment, talk about the 4 types of heat-related illnesses, and then, again, talk about assessment and emergency care for anybody that might have one of those 4 heat-related illnesses, and then talk briefly about lightning and a victim of a lightning strike, and how to care for a patient that's been struck by lightning, and then talk about prevention of heat-related illnesses. So these are just kind of the topics. We're going to briefly anatomy and physiology, again, the common heat-related emergencies, how to prevent it, lightning, and assessment and management. And if I start going too fast, let me know. We're already at almost 9 o'clock, so I want to be, oh, these are not my slides, but that's okay. Okay, we can just skip this, Jeff. I'm sorry. These are not the slides that I put together. So the body is adaptable, right? It's going to try to thermoregulate when we get too hot. It's going to try to keep us warm when we're too cold. It's going to try to cool us down when we get too hot. So the thermoregulation is the process by which our body does that. And 2 of the main ways that it does it are sweating. Literally water comes out of our body to help us cool us, or dilates the blood vessels in the skin to help cool our bodies. So be aware of the heat index. If you're working in an environment where heat is a factor, so that you are aware of what customers or patients might potentially be dealing with. So when there's a higher heat index, patients are at greater risk of heat illness. So we need to be aware of what the heat index is. Hydration, obviously, is a key factor in preventing any heat-related emergency. So you need to make sure that you're doing it yourself, and need to make sure that if you see someone who's out in the heat, make sure that they understand the importance of hydrating as well. And again, your body is adaptable. So if you've got prior exposure to heat, although it's not necessarily a guarantee you won't have a heat-related illness, if your body's better prepared for it, you can somewhat adapt and be better or perform better. And then physical training, of course, the better physically fit that you are, the better your body is able to adapt to a heat environment. So again, you've seen this slide before, just in a different format, heat loss, mechanisms of heat loss in the body. So we're just looking at it from a different perspective. So I'm not going to go over them again since we've already covered them, but I am going to ask you a test question. What or which of these following mechanisms is the body's most important cooling mechanism?
Evaporation.
Did somebody say that?
Evaporation?
Evaporation, yes. So that's another test question. Evaporation is the body's most important cooling mechanism. And that's usually we sweat and help evaporate that heat off of our bodies. So again, make sure you understand these mechanisms of heat loss. You could see them on the test, possibly in different formats. All right, next slide, Jeff. Can we just skip through some of these because okay, good. So here are some heat syncope and heat cramps. We're going to talk just briefly about common heat-related emergencies. So syncope or fainting is cardiovascular related, and it's temporary. So you just lose consciousness briefly, or you faint, which is another word for syncope. So that can often occur in the heat or extreme heat. Or heat cramps. Essentially, this is a muscular type issue. So your body or certain muscles cramp. And that's usually due to an electrolyte imbalance or dehydration issue. Okay, next slide.
Come up to a mountain bike, you'll see that at least once or twice this summer.
Yes, you see a lot on the mountain bike trail, which is it's kind of a fun thing to work. You see a lot of different types of situations than you do on the snow. So next two types of heat-related emergencies we'll talk about are heat exhaustion and heat stroke. So heat exhaustion obviously occurs in a hot environment, especially after you've been exercising. And some of the symptoms that you might see or hear a patient complain about are exhaustion, dizziness, nausea, headache. They could also have leg cramps, and they could be sweating excessively and have decreased urine output. So what Tracy referenced earlier, the ins and the outs, would be an important question to ask in this situation. For heat exhaustion, your body temperature is less than 104 degrees Fahrenheit. And you might be mildly confused, but for the most part, your level of responsiveness is normal. Conversely, heat stroke is a life-threatening emergency, and that is usually characterized or identified by a decreased level of responsiveness, and your body temperature has actually risen to above 104 degrees Fahrenheit. So again, the patient's level of responsiveness is decreased, and it could get worse, and sweating could have actually stopped at this point. And if that's the case, then that's the point where you should initiate immediate treatment and evacuation to a next level care facility. And the heat stroke can actually occur from exposure to heat with or without exertion, so they may not necessarily be exercising, but may just be overexposed to heat in this case. And when you have a patient with heat stroke, the body's normal compensatory mechanisms have just been overwhelmed and can no longer keep up. So again, this is a life-threatening emergency, and if untreated, can result in death. So be aware of the difference. I'm sorry, go ahead.
Oh, does anyone know the name for excessive sweating? It'll be probably on the test 2-3 times. It's not sweating.
I know.
It starts with
diaphoretic.
That's it, diaphoretic or diaphoresis. Mm-hmm. Just make sure you know that word.
Okay, you can kind of skip through that. I think I just talked through most of these slides, so I apologize. So how can you prevent heat-related illnesses? Again, you would think that some of this is common sense, but it's our job to make sure that people are aware. Hydration. You have to ensure that you as a patroller are properly hydrating, and make sure that you encourage customers to hydrate as well. So light yellow urine is a good indicator that you are well hydrated and something you should pay attention to. And then, of course, you have to be prepared for the heat. So you have to wear light colored clothing and layer it, and definitely should wear a hat. A wide-brimmed hat is actually recommended. But you don't want tight-fitting clothes, and you don't want to exercise or exert yourself in the hottest part of the day. And if possible, rest frequently in the shade. Another heat-related emergency is sunburn. I'm going to go out on a limb and say that most of us have probably had one, so you know how they happen. So one of the most important things that you can do, again, is wear light clothing but long sleeve clothing that covers your body, and they even have clothes now that have UV protection built in. If you're not wearing that, you should definitely have sunscreen on your face, arms, any part of your body that's exposed to the sun. And again, as part of our risk assessment in the morning, in our morning meetings, we recommend, and Fred reminds all of us, to wear sunblock. We remind customers to wear sunblock. Just because it's not sunny and just because it's cold doesn't mean you can't get a sunburn. So things to consider. High altitude, snow and water all increase your vulnerability to the sun. So those are the environments that we'll be working and playing in. So sunblock is of the utmost importance. Okay, next slide. Again, we've talked about this clothing, sunblock. Okay, so lightning is a big, can be a big factor actually at Ski Apache, and it's something that we deal with frequently in the summer months and also sometimes in the winter. So I think we all know what lightning is. It's a discharge of electricity from the atmosphere, and it can be dangerous. Even though you only have a 1 in 5,000 chance of being struck, it does happen on average 62 deaths per year, and it's completely unpredictable. And that's why there are so many things that you can remember about lightning. But the one thing is, if you see it, flee it, and if you hear it, clear it. So if you hear thunder, seek shelter. If you see lightning, seek shelter. Next slide, please. We have, this is an example of a patient that's actually been struck by lightning, and what that might look like. We have multiple apps that people use on the mountain, but I think, I don't know which one is the definitive, if it's WeatherBug or, but somebody is always paying attention. And it's usually Fred or somebody else on the mountain paying attention to how far lightning is away. So part of our job is that when there is lightning, we encourage people to come indoors, seek shelter. All the lifts, we get everybody off the lifts closed. Everybody is encouraged to get inside and out of the lightning because it can be deadly. So lightning injuries can be very severe. They can cause respiratory arrest, cardiac arrest, and can cause severe tissue damage, as you could see in the previous picture. It can also cause internal injuries that may not necessarily be obvious right away because you can't see them. Next slide. So again, it's unpredictable neurological deficits. Does anybody know anybody that's ever been struck by lightning? I don't. I'm just curious as a kind of a discussion point. I've never met anyone that's been struck by.
I think the guy down at Ski West got struck playing golf up in Rio there. So the Wild West ski shop.
Oh wow! Okay.
And one of them died a few years later, and the other one I can't remember their names. I used to know him. He looked like the guy from Gentle Ben. Anyways, he had problems. I mean, he still has problems.
Yeah.
I saw at a mountain bike race. all these people were standing around next to their tent with the aluminum poles, wondering why their arms were. Why the hair on their arms was standing up.
Oh, jeez.
They weren't directly hit far enough away that it actually didn't injure the dog, but it knocked him out.
Crazy.
Yeah.
So it does have a 30% fatality rate in a lightning strike. So, okay, next slide. So again, you'll hear and learn this as you're up on the mountain. We have, very strict and definitive rules and procedures that we take when lightning is close. But obviously, we'll all seek shelter as soon as you possibly can. Clear the ski lifts and any exposed structure that would leave you vulnerable. Okay. So in a lightning strike or heat-related emergency, well, we'll start with just heat-related. So it's your standard assessment, and you're going to see that's a theme in almost everything we do is your standard assessment, A, B, C, Ds, and vitals. And you'll check their skin temperature and appearance, look for any, check for muscle spasms or cramping, and you can ask if they're conscious. I've never had or been able to or been asked to determine a core body temperature. I don't know if it's something that anybody with more experience has ever done. I personally have never done it. But as Tracy mentioned earlier, you can look for behavior changes, the umbles, stumbles, mumbles, grumbles, and then look for any burns or trauma. And that's your assessment. And then we'll look at the next slide as management. So in a heat-related emergency, you obviously get them to a cooler or a shaded location. Continue to monitor their condition and their vitals. Give them hydration, water, and oxygen if they need it. And then position them for comfort, get them to relax, and then treat for shock if necessary. And if they've come to you in the first aid room, probably need to limit re-exposure to the heat or the sun at that point, and then transport as appropriate, whether it's they go home or they go to a definitive care facility. Okay, next slide. So this is the chapter summary. One thing I forgot to say about lightning is that in a triage situation, somebody that's been struck by lightning is actually a first priority in a triage situation, and we might address that in multi-casualty incidents at some point. But because the chance of survival after cardiac arrest after lightning is actually better, so you would actually give CPR to somebody who's not breathing after a lightning or not breathing and has no pulse after a lightning strike. So just one, I just thought that was an interesting point to make when talking about lightning strikes. Okay, so chapter summary, again, look through these slides when you have a chance, because a lot of this stuff, again, will be on your exam, even though it's not something you think you would deal with on a regular basis. But you can just kind of click through them, Jeff, if you like. Important things to remind your customers are the type of clothing that they're wearing, loose fitting and light colored. They need to be wearing a hat. They definitely need to be drinking plenty of water or electrolyte drinks, and then wearing sunblock to prevent sunburns. And I think, I can't remember if this is the last slide or not. I think that might be it. Okay, there was my triage situation, yes. Care first for lightning strike victims who may appear dead. Okay, that's 26. Any questions, concerns, comments?
Side remark?
That too. Keep it fun.
Let's see. Anybody need a break?
Good.
Whoop.
Everybody good? Jeff, and I know it's 9:15, so if you just want me to keep plugging through? Or if you have any...
Can everybody hang out and finish these chapters?
Yep.
Okay. If you have to drop, catch the replay on your own.
Okay, I'm hoping 27 is, yes, okay, good, it's mine, because this was an abnormally long slide deck. And it was huge. There was like 88 slides in this slide deck. And again, I don't want to minimize any chapter in the book, because the bottom line is there will be at least 2 to 3 questions from every chapter on your test. So chances are you may not see a lot of this stuff, but chances are it's going to be on the test. Some of it will be on the test. So I've tried to pick out some test questions. So if I'm going too fast or if I've skipped too much, please let me know. But there's a lot of information in this chapter. But in the interest of time, I'll just kind of breeze through some of this. So in animal and plant emergencies, we're going to talk about the difference between a poison, a toxin, and a venom. Those are key objectives because you'll need to know that for the test. We're going to talk about common toxic plants and how they can be harmful. And then we're going to talk about briefly, actually we're only going to talk about land animals. I'm going to skip over the marine creatures in general. I know it sounds kind of funny to say it out loud. Okay, next slide. We are going to talk about the assessment of a patient that may have encountered a toxic plant, animal, or marine life, and then we're going to talk about how to manage exposure to some of these things, and then proper management of wounds caused by animals, including reptiles, insects, and spiders. So again, I'm going through these quickly, but these objectives will be covered on the test, so make sure that you're paying attention. And these are just the topics listed again of things we're going to cover. So Jeff, you can go on to the next slide.
Okay. Oops. Skip again?
Yes, please. I'm sorry. I'm hoping, yeah, I think this is my deck. I hope it is. So when we talk about plants and animals, the primary organ of injury is the skin. So make sure that you are familiar with the layers of the skin, the epidermis, the dermis, and the hypodermis. You've covered this in anatomy and physiology, so I'm not going to wear it out again, but important that you know these layers because the type of venom or toxin or poison can have different effects on different layers of the skin. So just make sure that you're well versed in that. And this is just a picture of reddened skin to give you, this is an injury or some sort of injury to the top layer of the skin. Okay, so two important things to note. One, organs with a high vascular supply, so your major internal organs are going to absorb toxins rapidly, and then those conversely with the lower vascular supply, for example, your extremities, increase the potential for infection. So important things to note, two things that you'll want to think about when you're thinking about plant and animal toxins, poisons, or venoms. So again, this is a really important distinction. I think there's actually more than one test question, or at least in the test bank, formatted around toxin versus poison. So the simple breakdown is a toxin is from a living creature, a poison is from a living creature or a non-living substance. And then a venom is a toxin or poison specific to a certain animal. So that one makes the most sense to me. Sometimes toxin, poison, I get them a little mixed up. But a venom is from an animal, a snake, a spider, or a scorpion. So important to know the distinction between those.
Venom has to be injected, right? Isn't that the difference?
Yes, venom has to be injected, whereas you can come in contact with a poison or a toxin.
Like a frog.
Yes, poison tree frog. So here are some examples of plants that are toxic to the skin. This slide deck literally broke down every plant toxic to the skin, and each one had its own slide with picture. You'll see that in your OEC book. Again, I did not do that here, so this is, I think this is poison ivy that you're looking at in the actual picture, but ivy, sumac, oak, and then stinging nettle are four types of toxins to the skin. And I think stinging nettle is actually present up at Ski Apache. So something that you may potentially come in contact with, or one of your patients may come in contact with.
And one thing on those, don't use water to clean them off. It has to be alcohol or soapy water, or you spread it all over.
Very good point. Okay, so those are plants that were toxic to the skin. These are plants toxic to ingestion. It's a very long list. And again, the slide deck broke down each type of plant and where it's found, the symptoms associated with ingestion, and then also the severity of ingesting one of those. So again, I'm not trying to minimize this because there will be these random questions, there could be these random test questions about ingesting rhododendron, or what happens if you ingest a lily of the valley. So it's important to understand that level of specificity when you look at plants toxic to ingestion. Poisonous mushrooms. Here are the different types of poisonous mushrooms. And again, it's important to know where they're found and what would happen if someone ingested one of these types of mushrooms. Okay, I made this slide, and I called it bug out, even though they're probably technically not all bugs. But these are all the different types of creepy crawlies that you could potentially, or a patient could potentially encounter. So spiders, ticks, scorpions, bees, wasps, hornets, mosquitoes, ants. In your book, you'll know they talk specifically about different types of spiders and where they're found and what their bites might look like. And for example, a spider bite that can resemble a bullseye target is most often caused by what? Does anybody know? Bull's
Is that a
eye
brown
target.
Black
What's
widow.
that?
Is that a brown recluse?
No.
Black widow?
Black widow, yeah, a black widow. So those are some of the types of questions that you might see on the test. So when you're reading and studying, pay attention to things like that. Bees, wasps, and hornets, obviously people can have severe allergic, anaphylactic reactions to. So that's something else to be conscious of. And the differentiation between a bee, a wasp, and a hornet, it's quite an education if you don't already know it. And then mosquitoes obviously can carry and transmit disease, as well as ticks. So being able to identify the different types of diseases that might be carried and or transmitted by ticks and mosquitoes, and where they're most prevalent relative to the part of the country that they're found in. Okay, and then my least personal favorite, reptiles. I left out the part about alligators because if we see one, I'm out. I'm done. If there's an alligator, count me out. But there may be snakes. So make sure that you understand the different types of snakes that could potentially be found in certain parts of the United States. So for example, the phrase, no snake. So how about this one? You guys probably know this one. The phrase, red on yellow, kill a fellow, red on black, venom lack, is helpful in identifying which type of snake, of poisonous snake.
Coral snake.
Coral.
Ooh, very good. Coral snakes, good. So those are things that you need to be aware of. That's a test question, for example. But be aware that, in a mountain situation, there could potentially be encounters with snakes, most likely in the summertime, and what to look for. Okay, next slide. I know. Oh. So lions and tigers and bears, this is where I combined all my mammals. Again, if we have a lion or a tiger, I'm out. But we may, on occasion, there are bears in the mountains. What you're looking at here if you look at the screen right, is a horse bite.
Oh, for heaven's sakes.
I know, poor baby. And then on the left is a dog bite. Mm. So, we do have dogs that come up to the ski mountain, both in the winter and in the summer. They're allowed. They're supposed to be on leashes, but we all know that things can happen. So there is a section on mammal bites, mammal encounters, and specifically dog bites and how to assess and manage those. But these are all things that you could possibly encounter. So as far as assessment, is there an immediate life-threatening situation? And of course, again, our theme, A, B, C, D. We're going to start our assessment with that every time. And then, is it a bite? Is this a plant? Or is it a large animal trauma? And if it's an allergy, are they allergic to bees or wasps? Do they have an EpiPen? And then do you see bite or fang marks to help you determine what type of injury or bite this might be?
It is, if it's possible to get the critter without endangering yourself, then you want to bring that in with the patient. But it's not, you're not going to wrestle a dog.
Why not?
If it happens, I got it. Capture them under glass, send it with the patient.
Okay.
All right. And then next slide. And then assure scene safety regarding creatures or plant life. So if they've been bitten by a dog, is the dog now restrained? Or is it still running loose? Is it a potential threat to you or anyone else? Is there a snake? Is the snake dead, or is the snake still nearby? So make sure that you're assuring scene safety for the patient as well as yourself. And then, of course, observe all standard precautions. You're going to learn and hear about that all summer long. And then manage A, B, C, and D, and call for advanced life support if needed, if you think that transportation off the mountain is going to be necessary. And then if it has been a trauma from a large animal, then you want to assume a spine injury and act accordingly with immobilization and transport via backboard. And then if necessary, again, per the situation, get them evacuated and transport them to a definitive care facility. So here's a chapter summary. Most of the time, coming in contact with a toxic plant on your skin is not life-threatening, but they could become infected, so they should be treated and evaluated by a physician. And then minor bites from wild animals are not usually life-threatening, but you do have to consider rabies and the extent of the actual soft tissue damage from the bite. Next, okay. And then, again, just some bites or scratches by certain small animals could warrant evaluation for rabies. And then if someone has ingested a wild plant or a mushroom and they have altered mental status or nausea and vomiting, they should be evaluated emergently.
Hey, Van, we did have a case of an employee who got the hantavirus.
Oh, wow.
So we think it was going down to, where we store all of our pads, and so there were some places where a lot of rodents, mice had been around, and it was Amber Luna got it.
I thought I saw something about that. Yeah, that's crazy. Okay, good to know. And then finally, you would manage any large bite and injury as you would any traumatic wound, and I'm sure we're going to get more information about that coming forward. And then stings, unless somebody is severely allergic, can usually be managed with localized treatment. Okay, so I think that's it for Chapter 27. Again, I really, really, really pared this down, just given the number of slides. So if you have any questions or concerns, please ask now, or please follow up with any of us later.
In terms of test-taking strategy, those, if you had, not saying you should ever lighten up on your studying, but those would be the ones if you had to study harder, choose anatomy versus, animal bites, and do anatomy.
Good point. Okay, moving on. Chapter 28, altitude-related emergencies. This is something, has anyone on this call ever administered oxygen?
Yes.
I probably should hear like 16 yeses. I know a lot of you have. Well, if you haven't, you are going to, and you're going to do it, 8 to 10 times a day, every day that you're on the mountain when you're working in the first aid room. It's one of the most common types of emergencies that we treat in the first aid room. So if nothing else besides the test, get good at this because you're going to do it a lot. So just for today, we're going to define what altitude is, talk about the basic principles of altitude physiology and why we see altitude-related illnesses, and then talk about some risk factors and how you can employ some strategies to prevent altitude-related illnesses. Okay. And we're going to talk about 3 specifically, acute mountain sickness, high-altitude pulmonary edema, and high-altitude cerebral edema, how to assess a patient, and then the treatment of a patient with altitude illness. Okay? And these are just the topics. So we'll start with some physiology, talk about the problems, prevention, assessment, and management, and then we'll summarize and move on. Okay, so can somebody briefly, what is altitude? The basic definition.
It's how you feel about things. It's my altitude.
That's your altitude.
Dude.
You have a high altitude then. You have a very positive altitude, Jeff. That's what I like about you.
Stuff.
Height above sea level.
Yes. So in the layman's terms, it is the height or vertical elevation above sea level. So it's defined different, they've got low altitude, intermediate altitude, high, very high, and extreme altitude. So Jeff and Tracy, correct me if I'm wrong, but the definition of high altitude is an elevation from 8,000 to 12,000 feet. So I think just by virtue of showing up in the parking lot, we're operating in high altitude.
Mm-hmm.
So that's why we see a ton of altitude-related illnesses, and fortunately we see a lot of just the basic or, less serious altitude-related illnesses. But so again, when we talk about physiology, your body is very adaptable and tries to adapt to any condition, and altitude is no exception. So your body does things to preserve homeostasis when it experiences a change in altitude. How fast you ascend determines the probability of getting altitude sickness. So the faster you go up, the higher the chance that you will experience some sort of altitude illness. Next slide. So we talked briefly about the altitude classifications. For our purposes, we operate and work in high altitude. I think the parking lot and on up, all of that falls into a high altitude. So altitude illnesses most commonly occur in the high altitude range. So that's why we're going to talk about it and why it's so important. And here they are, just to give you the different classifications. Okay, next slide. So what does your body do to try to help you out? Your body recognizes that it's ascending, so it's going to increase your rate and depth of respiration. So you're going to breathe faster and you're going to breathe deeper because your body is saying, okay, I'm going to try to get more oxygen to my cells because we're going up higher. Your heart rate is going to increase, get more oxygen or get more blood to your tissues. And then you're going to have an increase in red blood cell production. And it starts immediately, but it doesn't really quite help you out until after probably a few days. And I don't think ultimately you'd probably have to be at high altitude for at least a week or two to fully realize the importance or the impact of increasing your red blood cell production. And then it also constricts a constriction of your pulmonary blood vessels and increases enzyme production. All of these things to try to help you function better in a high altitude environment. So next slide. So even though your body is compensating and trying to make it easier for you, it doesn't always work, so you can experience some altitude-related problems. So let's take a look at what some of those might be. So we're going to talk about 3: acute mountain sickness, high altitude pulmonary edema or HAPE, and then HACE, high altitude cerebral edema. Okay, so the next slide. Oh, sorry. So here's some that we're not going to talk about. So here's some of the other altitude-related problems that you can read about. There will be potentially some test questions. I looked through the test bank. I didn't see a huge, but Kumbu cough, peripheral edema, high altitude retinal hemorrhage, radial keratotomy, eye surgery. I guess that's could be a potential risk for being at high altitude. So these are other altitude-related problems. I'm not going to cover them tonight, but they are covered in your text and could potentially be test questions. So how can we prevent altitude? Well, let's see. Next slide. Prevent altitude illness. So this always cracks me up because we tell people the best way to prevent altitude sickness is to come up a few days early, come up and spend a few days at high elevation, and then don't exercise or do anything strenuous, for 24 to 48 hours. But what most people do is drive up that morning from Oklahoma, go straight to the top, and start skiing. So it's a recipe for disaster for a lot of people. It's not to say it's going to happen to everyone, but all the pieces are there for acute mountain illness to occur. But the best way to do it is to ascend gradually. So you should probably come to Ruidoso and stay for a day or two before you head up to the top, and then avoid what's that?
Drink on. I said you forgot the 12-pack they drink on the way up.
On the way up, yes, exactly. So, I mean, the conditions are ripe, and you're gonna see it all as far as acute mountain sickness in your first season, I promise. So there are ways so this is one part of it. So ascend gradually, avoid a rapid ascent above 10,000 feet. We break those two rules right away. And then try to incorporate a layover at an intermediate altitude. In a perfect world, that would all be done, and this is how you can prevent altitude illnesses. Okay, next slide. So as you increase your altitude, more rest and less altitude gain per day may be necessary. So for most people, they're coming to the ski mountain, so they're going to go up to 11,000 feet, and then that'll be the highest that they go. They're not going to go up above that. But again, it says to avoid physical exertion for the first 24 to 48 hours. Well, you're on a ski vacation, so that's probably not going to happen. Okay, next slide. Staying hydrated can make a difference while you're skiing or at high altitudes. So we encourage patrollers and customers alike to drink lots and lots of fluid, 3 to 4 quarts a day. So it's definitely more than you would drink if you're already a big water drinker. Double that is what you would probably need when you're at altitude. So you should be peeing all day, and it should be copious and straw-colored. So if somebody comes to the first aid room at 3 o'clock and they haven't peed all day, that's probably not a good thing. Next slide. Avoid alcohol and other depressant drugs. Hardy har har. Lots of people drink and ski all day long. So things to be aware of that can contribute to acute mountain sickness. A high carbohydrate diet, which is something we tell people when they're there if they get sick first thing in the morning. And then really the only way to resolve altitude illness completely, especially acute mountain sickness, is just to go to a lower altitude. So one thing that will make you feel better. So when you're assessing somebody for acute mountain sickness or any altitude-related illness, if they're not conscious and need life-saving equipment, then by all means initiate that. But it's the same thing we do every time, A, B, C, D. And if they're conscious, get a sample and then start your OPQRST. I'm not sure. Have you guys been exposed to that yet?
Yep. But
okay,
it wouldn't hurt to go through them.
Sure. So onset, when did you start feeling this way? Provocation, what makes it feel worse? What makes it feel, or does anything make it feel worse? And then the quality of the pain or the illness that you're feeling. Radiation, I guess more in a trauma situation would be, does it radiate away from or to a certain area? And then I think that's severity, right? Yep, severity of your pain or illness on a scale of 1 to 10. How bad do you feel, or how bad does it hurt? And then timing, when did it start? When did you start feeling this way, or when did you first feel this pain? So,
that T is change over time.
Change over time. Is it getting better, or is it getting worse?
Yep.
Okay, so that's one of the first things you'll do in assessing an altitude-related illness. And then management. Again, ultimately, the only thing to completely help it resolve is to descend to a lower elevation. But we have things that we can do in the patrol room to help with acute mountain sickness, HAPE or HACE. I think we're going to talk about those here. Next slide. Nope, we didn't. So I'll talk about, I think you're going to cover oxygen administration for acute mountain sickness, but acute mountain sickness is something that you'll see it 8 to 10 times a day, if not more. And some of the things that you'll hear as symptoms from people that walk in the first aid room are, I have a headache, or I'm feeling nauseous, and they were fine until they got to the parking lot. Some people will not just feel nauseous, they'll throw up. Some people can pass out. They can get cold and clammy skin. They can get very pale. You'll see all sorts of variations on acute mountain sickness. Even had one young kid, 28 years old, said he could not recognize words. So he was looking at his cell phone, but he couldn't read. And this was a person that could otherwise read. So he came in on his own. So all kinds of things that can present, but those are some of the most common: nauseous, headache. They have already thrown up or feel like they're going to, or they could have possibly passed out. Usually with oxygen and some hydration, a lot of times people will walk out of the first aid room and be fine for the rest of the day. Some people may come back 2 or 3 more times and just decide that it's not for them, and the only way that they're going to feel better is to go back down. So acute mountain sickness is the less severe of the altitude-related problems. The second is high altitude pulmonary edema, and this is where fluid actually accumulates in the lungs, and this is not necessarily due to a pre-existing cardiac disorder. So this could occur in an otherwise healthy individual. Sorry, I'm going to take a drink of water.
So hey, any edema is an accumulation of fluid. Think pulmonary is the lungs, pulmonary edema, and then HACE is cerebral edema, so accumulation of water on the brain. And either one, you're going to recognize the signs and symptoms differently. Obviously, HACE is going to be altered mental status, which, by the way, same acronym, 2 different things: altered mental status or acute mountain sickness. When you take exam, read carefully. There's one bad question in the test bank where AMS is the answer, and you're not sure which one it is. So anyway, but we really don't have any treatment for the last 2. All you can do is say that's call EMS.
So really the only things you can do is call EMS. They need to be transported to a lower altitude as quickly as possible in high flow oxygen until they can get lower. Okay, and I think that is all this. So the next is the chapter summary. So again, those 3 are the focus for the presentation. There are others, but most of the questions in the test bank seem to be related to acute mountain sickness, HAPE, and HACE.
Know this word right here.
Oh, sorry.
That's okay.
That's all right. Ataxia?
Yep.
Can somebody define that, just in case somebody doesn't know?
Not walking normally.
Exactly.
Off balance.
Mm-hmm.
Wait, 29?
29. We're in the home stretch. And again, don't want to minimize anything, but our last chapter is water emergencies. So we're going to talk about dry drowning versus wet drowning. Actually, we're not going to talk about the mammalian diving reflex, although it is part of. There are a few questions about it on the test, maybe one, not a few. But we're going to talk about the different terms: submersion injury, arterial gas embolism, drowning, near drowning, and decompression sickness. If we have any divers on the call, you're probably very well versed in that.
Mm-hmm.
We could see it just because, for example, there's a diving hole in outside of Albuquerque, and so if you were to dive and then be stupid and go right up to the peak, you could see decompression sickness on the mountain. Unlikely, but.
And again, we do have a pond and a creek, so there is a slight chance. We actually have a process for rescue on the pond, which I learned in my class last summer. So there is, I guess, a rare chance that somebody could end up in the pond, unless they're doing it on purpose in the pond skim.
Even in the winter.
Even in the winter, absolutely. So.
The pond was in the middle of the hill at spring break last year.
Isn't that the truth? I ski through lots of water.
Ground.
Yeah. Okay, so at the end of your studies, you should be able to define the laws that were, no, that's okay. Boyle's, Henry's, and Dalton's law. There are a few test questions about those laws individually, so make sure that you're writing that down and taking a note and studying your test bank questions. Okay, so just keep on going. Next slide. And these are the last two objectives, and we are going to talk about signs and symptoms of water-related emergencies, and then how to manage a patient that suffered one. So we'll talk briefly again, anatomy and physiology, common water emergencies, preventing them, assessment and management. So obviously when a person's airway is submerged underwater, or any other liquid for that matter, for more than a few seconds, the process of breathing is interrupted. So that just sets into motion a series of events that completely or immediately affects homeostasis. So unless you get your head out of the water or whatever it is you're in, you can very quickly die from drowning. So the pathophysiology of drowning involves primarily the respiratory and the cardiovascular system. So can anybody describe or tell me the difference between dry and wet drowning? Anyone?
Bueller?
Bueller? Okay, so drowning can be classified as dry, which is actually more common, and that's where you would aspirate a small amount of fluid, and a violent or like very severe laryngospasm seals your airway and you die. Yep. So dry drowning actually usually happens before wet drowning, although you can drown from wet drowning alone. And so wet drowning is where the laryngospasm is minor, or the airway muscles quickly relax, allowing all the water to flood the lungs. So if you think about it, it's a pretty, so it's wet drowning is the fluid floods your lungs, and that's how you drown. So definitely know the difference between dry and wet drowning.
Hey, Vann, do you recall the name for it? I know it's on the test. There's a syndrome when drowning victims, so they're resuscitated, but then they die several days later.
Is it secondary drowning or near drowning?
I think you're right. Secondary drowning.
Secondary drowning. So drowning is when you die within 24 hours. Secondary drowning is death from drowning that occurs 24. I think it's to 72 hours after a water emergency. So secondary drowning. That's definitely a test question. Okay, so I do think there are also questions relative to the mammalian diving reflex.
Yep.
Okay.
That's essentially, it's think of a dolphin or a whale, that it's a reflex that's peculiar to mammals. When you dive in cold water, your heart rate slows and your respiration slow. And that's allow mammals, to be able to stay underwater for a long time. And humans actually have it as well. That's why people who drown in cold water tend to, they can usually be resuscitated, even if they're underwater a long time.
Mm-hmm.
I think that covers what you need for the test.
Yep, that's perfect. Okay, so here are some common water emergencies. So submersion injuries, obviously being submerged underwater, barotrauma, nitrogen narcosis, swimmer's ear, I'm not sure would be classified as an emergency, but it does hurt. And then breath holding, any sort of trauma that could occur in the water, which there could be multiple. And then, of course, any interaction with marine animals could cause a water emergency, or aggravation of an existing condition, whether it's respiratory or cardiac, something that you already have. So water emergencies can be numerous. In submersion airways, this, you always hear people say you can drown in 2 feet of water because only your airway needs to be submerged in order to drown. So be familiar with the types of drowning is drowning, and that's where patients die in the first 24 hours. And then there's near drowning, and that's survival for more than 24 hours after being suffocated by submersion in liquid. Primarily or mostly water, and then secondary drowning, and that's death after submersion in water within 24 to 72 hours. So those are definitely 3 classifications you need to be familiar with. And then the temperature and salinity effects can all have effects on how, or can be temperature of the water in drowning, as Jeff just referenced, can be a factor in whether or not somebody could be resuscitated or potentially be resuscitated after drowning. And then aspiration and pathogens. Obviously, water contains millions of suspended particles that could be aspirated, causing all kinds of a host of problems, depending on how big they are and what they are. So this is just a slide. We've talked about this, I think, enough already, but submersion injuries, wet or dry drowning, and what that might look like, and how somebody could drown. So barotrauma, if you are a scuba diver, that's who is mostly affected by these types of injuries. For example, decompression sickness, coming to the surface too quickly, arterial gas embolism, and then the squeeze and reverse squeeze. I am not a diver, so I'm not very well versed in all of these, but there are questions on the test about arterial gas embolism, and that's a rapid ascent in which a diver doesn't exhale properly. So gas expands within the lungs and the alveoli rupture.
Yeah, the embolism is caused by, as you dive, you're breathing compressed air, and the result of the compression is it forces nitrogen to be dissolved in your muscles. And so then as you ascend, if you ascend too quickly, instead of it coming out of solution into your blood, it forms bubbles that can form in a muscle, or they can form in your bloodstream. And depending on where they form, that embolism, that air embolus, can travel down, a blood vessel till it'll stop and block the blood flow, so you can get a stroke if it's in your brain. You can have a heart attack in your coronary arteries, and you can have severe pain if it ends up in a joint or an extremity. So, anyway.
Okay. Thank you. Thank you. Okay. Swimmer's ear. We've probably all had it. If you have kids, you've definitely seen it. It's an acute bacterial infection of the ear. It is very painful. It hurts to the touch, and sometimes can have a yellowish discharge. And essentially, you've got to get ear drops to prevent bacterial growth, and stay out of the water. So breath holding, another type of water emergency, and that's essentially, it's resulting from intentional hyperventilation. And I think it's very common, not common, but kids do it. It most commonly affects children and young adults they do it in a swimming pool. They intentionally hyperventilate to increase the amount of oxygen so they can essentially hold their breath longer. And this decreases the amount of carbon dioxide, which can cause the patient to then lose the stimulus to breathe, because you need that to breathe. And so then they could pass out and potentially drown. And again, it's most common seen in swimming pools with young children and young adults. And then trauma. So you could have multiple examples of trauma in water, whether it's from a marine animal, diving in shallow water, falling, or even a boating accident. Just a little picture of potential trauma. What's that?
I said that's terrible.
I know. And we talked about this somewhat in the previous chat with animals, but this could be traumatic, or it could be a toxin or a venom from a marine animal that could involve soft tissue. So preventing water emergencies, obviously avoid alcohol around water and know where you are. Are you swimming somewhere where there are rip currents, or is there a current? Or are you swimming in a lake and know how deep it is before you dive, before you jump? So that's just knowing your environment to prevent a water emergency. So again, our standard assessment would start just like anything else, A, B, C, D, vitals, level of consciousness, and then ensure your own personal safety. You don't just jump in after somebody with all of your clothes on to go save them. So understand what your protocols are in your water rescue environment. Use spinal precautions in that patient, so immobilize the spine. And then make sure you take history of the time in the water and pre-existing conditions. And then, again, just be aware that near drowning symptoms can be delayed. In an arterial gas embolism, assess for the signs and symptoms, and then for decompression, possibility of decompression sickness or the bends, 2 different types. One resolves in a short time. It might be painful and uncomfortable, but type 2 is life-threatening, and they need immediate transport. So management, again, remove from the water as soon as you possibly can safely for you. Establish an airway if they don't have one. Check their breathing, pulse, and initiate CPR or rescue breathing. Spinal precautions, and then treat for hypothermia and shock. And you can use high-flow oxygen to do that, and then treat their other injuries. And I don't know what Dan is.
Divers Alert Network.
Divers Alert Network.
Yep.
Thank you.
They dispatch a hyperbaric chamber for recompression.
Okay.
So.
Awesome. Okay, and management again is just demonstrating how the rescuer does it safely with a personal flotation device and a buoy to pull them in, or so reach, throw, then go. So it's kind of a little mnemonic to help you remember your own personal safety when rescuing somebody. You don't want to become a victim. And then in any water emergency, transport all patients because symptoms, again, may be delayed, for example, in a near drowning. And they may need specialized treatment, like in a decompression illness, like a hyperbaric chamber. And then, especially in a cold water submersion, even if they appear to be dead, resuscitation may be possible. So they're not dead until they are warm and dead.
Test question.
That is a test question. Okay, so in summary, again, spinal cord injury should be suspected in any patient with a submersion injury in which there was no witness, and then all near drowning because symptoms may be delayed should be transported to a hospital. And then consider decompression sickness and arterial gas embolism in all patients with a history of diving, and then high flow oxygen. Fancy. And just remember, they are not dead until they are warm and dead. And I think that is it for chapter 29. So any questions, concerns, comments? Or did everybody hang up because it's too late?
Still with you.
Oh, thank you. Thank you very much for your time and for answering my questions. I'm looking forward to meeting all of you, hopefully at some point this summer.
Yes. Yep.
Thank you very much. See ya.
All right, Jeff, anything else that I may have left out or cut too short?
Oh, whoops. Sorry, I was talking. I was on mute again. So I think everybody else, if you've been here before, feel free to hang up anytime. If this is your first time, so I think Brian maybe and Eve, do you want to just spend a couple minutes to go over resources?
Sure.
Okay. I'll give you a brief recap of our first meeting, and then what you can actually do, I'll show you how to get there. but you can go to YouTube to our Ski Apache YouTube channel, and when you know what, I'm going to put my headset on so you don't.
Okay, Jeff. Good night, you guys. I'm going to hang up.
Yep. Good night.
Good night.
Oh.
Thank you.
Yep. And I'm presenting, right?
What's that?
Never mind. No, that's okay. I got it. So
okay.
Hopefully you can see Google Chrome, and you can see my Google.
Do you see it?
Yes.
Okay.
You don't see it?
Yeah, I got it.
Oh, okay. I was going to say, wait a minute. So let me show you one other thing first. And actually, what I'm going to do, I'm on as Ski Apache right now, so I'm going to log out and log back in as me. Because I found out when you're on as Ski Apache, you have administrator privileges, and it doesn't look the same.
Yeah.
So I'll show you what you'll see if I log on as myself.
Okay.
All right. So now if I go to, we'll start at YouTube.
Mhm.
And I will get you this link. So see how here my list of subscriptions. I have Ski Apache OEC. You'll want to subscribe to this channel.
Okay.
You're still seeing your Google email.
You're seeing my what?
It looks like Google Drive.
You're seeing the Google Drive?
Yeah,
I'm seeing Google Drive.
Yeah, it's not on.
Really?
Yeah.
That's weird.
I'm still on too, and it doesn't look like you were moving around.
That's weird. Okay.
Oh wait.
How
there
about
it is.
now?
Boom. There.
The Apache OEC.
Okay. Yeah, you're seeing YouTube?
Yep.
Okay, and so here's, I mean, I've got a bunch of subscriptions in there, but so you see Ski Apache OEC?
Yep.
That's what you're going to want to link to. Now, I haven't built this out as nicely as others would, but eventually we'll get there. So if you go to videos, after tonight I'll have session 4 up here. So you can replay session 1.
Okay.
And that'll actually just walk you through what we're talking about now, about how to get on Google Drive and YouTube and all that. And then session 2 was our first academic session, I guess you could say.
Okay.
And session 3 was the big one. That's that one. If you haven't gone back and watched it, you'll definitely want to play that once or twice, maybe more.
Okay.
So they'll always be here for you to go back and review.
All right.
And do it as much or as little as you want. Now, if you go to playlists, this isn't super well organized, and I think as we get a little better at this is our first year doing online format, then I think we'll organize this a little better. But for now, it's kind of as good as I can get it, and I'll put some more thought into it. But some of these things, I've just accumulated them as a library. So like if in October 1st, what you guys are going to do is you'll do your mountain orientation with Susie Mitchell.
Okay.
And one of the activities, a lot of it is going to be patrol room, radio protocols. We'll probably even give you a chance to practice on the radio just a little bit.
Okay.
Go over paperwork, all that kind of stuff. But one thing you'll do is you'll watch a lift evac practice and a gondola evac practice.
Cool.
And that way you'll have seen it. You know, we're not going to have you do it, but you'll see it.
Yeah.
But all the skills are here. Well, not all. I can't say all, but a lot of the relative skills like knot tying, creating a harness, using a figure-8 device, they're in here. And so as a warning, and here's an example of a lift evacuation.
Oh, cool.
Please don't go out and try it on your own.
Do not try this at home, no.
Yeah, those skills, if you do it unsupervised, they will kill you.
Yeah, explain day.
Yeah, exactly. I don't have it here. I want to put it back in the fail section. That's just funny stuff for you to laugh at.
Okay.
There is a video we all watched, and it'll probably come out at Refresher this year, of you see 2 patrollers doing an evac, and every patroller sees it, goes, oh my God, they're doing it all wrong. They have the wrong type of device. There's no anchor. The angle of the rope is wrong. Everything. And as soon as the person being evacuated, it's a real evacuation, it's not practice. As soon as the snowboarder comes off the chair, he drops, not to the ground, but he drops pretty fast, and he yanks the patroller right up in the air, and they meet. They meet in the middle. And so the guy's friend who's on the ground filming, he's like, do you want a hand? So it's pretty funny. This playlist is one of my favorite. It's just behavior. It'll apply to the behavior emergencies chapter. It's all sorts of videos of people getting pissed off and beating each other with ski poles.
Oh, nice.
This is injuries just to help desensitize you to some of the stuff you might see. But here's your big one: is OEC skills.
Okay.
And as I'm finding them, I'm putting them here. So I would highly recommend before you come out Saturday.
Yeah.
Anything that's on the skill list. It's like Sam Splint. Don't worry, we haven't seen it yet. But patient assessment. Check that out.
Okay.
Let's see. Bleeding control. I think we talked about.
Okay.
Carabiner tourniquet is another skill to look at. I wish I could get these in order. Oh, sample. Watch that as many times as you can.
Okay.
Vitals, watch that over and over.
Okay.
I think a lot of these others we haven't done yet.
Oh, a second test wound. Cool. Not that I'm an RN, so.
Oh, yeah. Well,
not that I want
and by all means, well, and as an RN, that's going to be one of the interesting things for you is when you're on the hill.
Yeah.
You're only held. People don't know that you're a nurse.
Yeah.
So we expect you to operate at an OEC level.
Yeah.
It's your personal moral and ethical choice. Do you operate at the nurse level? Do you identify yourself, say, hey, I'm a nurse, I can take over, and then intubate a person? If you're willing to do that, great. If you're not, you're okay to practice at an OEC level.
Yeah, intubation's outside of my scope of practice. Like I said,
well.
I could.
There we go.
I mean, I've seen it done a million times. I've assisted with, not like actually doing it, but, the holding the airway and stuff. But
we have IV equipment on the hill for the paramedics.
Cool.
And, if you want to say, I'm sure Fred would probably want to get to know you better first, but if you want to say, hey, I'd love to assist doing this IV, they might say, well, you're a nurse, go ahead. And if there was a doctor on site and you can act under his medical license as well, then you could do that.
Okay.
But so that's what'll be really important for you. Your skills are a couple steps above everybody, or 3 or 4 steps. So you just need to know what's OEC so that you're acting at that level.
Yeah, totally. And I think it's cool, like, the outdoor emergency medicine, that's a whole new, that's awesome thing for me to expand my knowledge. That's cool to me.
Yeah.
I'm excited to learn that. That's really exciting to me.
Yeah, you'll have a lot of fun this winter or this summer. We may see some. We had a guy. He went down the expert mountain bike trail last summer, and Supermaned off his bike and slid 30 feet on his face, chest, and legs.
Ooh.
And
nice.
he came in looking like a burn victim.
I was gonna say he probably had like hamburger.
Yeah. Well, then last year I had a patient on the bike trail with a lacerated liver.
Goodness gracious.
We didn't know that until it was a 3-hour evacuation.
Woo.
And so we were talking about sunscreen, and I was teaching OEC that day, and they came in and they're like, my buddy's really hurt real bad, and I was the only bike patroller on the hill other than Fred, but Fred was somewhere, I forget. But so I said, and my bike was already locked up, so I said, give me your helmet, give me your bike.
Yeah.
And I jumped on the gondola and went to the top, and I got down to him, but then he was down in the boulders, so we had to extricate him first with, we had to, we snagged every person that went by. We said, stop, get down here and help.
Yeah.
and then we backboarded him, brought him back up to the bike trail, and then it was probably an hour just to get to that point, and then it was 2 hours to get him off the hill.
Goodness gracious, man.
Yeah, and by then his abdomen was rigid.
Oh, okay. I was going to say, how did he present? He started bleeding like crazy because of that lacerated liver like that, yeah.
He seemed normal at first. He just was in a lot of pain.
And
we got almost all the way to the bottom, and he said, can you guys stop? I got to vomit. So we roll him.
Yeah.
and let him, and he had like dry heaves, but he said, would you check my abdomen? It doesn't feel right. So I said, all right. We recheck his abdomen. It was rock hard. And I looked at the other patroller, and he just got his radio and said, EMS, why don't you drive your rig up the hill?
Yeah.
So they they came up the Jeep trail and met us.
Yeah.
Yeah.
Man.
So,
he did it up big, didn't he?
Yeah, interesting stuff. So anyway, this is
cool.
I did subscribe. Oh, I only subscribed to one channel. The Canadian. You know what that is? That's the Canadian Avalanche Rescue Cat Association.
Oh my God, that is.
I'll let you guys log in and check it out. If you see, well, here I'll play you the very end.
Oh my goodness! Look at that. Oh, I've never heard of that. That's awesome.
You can watch the whole thing.
Yeah.
It's about the history of avalanche cats.
That is the coolest thing.
This is a new deployment method for avalanche cats.
Super kitty. That's hilarious. Oh my gosh.
Here.
That's cool, man. What a brave pretty cat. Oh my goodness.
Cat. Loading cat. Pressuring up the gun. What's the pressure? Go to 200 for this shot. Pressuring up gun to 200. Safety off. Clear to fire. Clear. Fire. Fire.
That's one of my favorite videos. So that is that's a channel on our channel.
Perfect.
We'll get better with it over time, but anyway, that's YouTube. But that's kind of your hub for. I missed the class. I'll come back here.
Okay.
I'll see if we can get a way to record the practices and post them, but I think that's going to be more of a challenge.
Yeah.
So it's just real important to get up for the ones I okay, let me show you that. You should have a syllabus. If you don't, it's coming.
Okay,
so
yeah.
This is it. So this Saturday, this Saturday is our first live session on the Hill.
Okay.
So now if you have the rule for CPR is you're required to be certified at a medical provider level.
Yeah.
And you have to demonstrate to a CPR instructor every year that you have competent skills, which is different. So if your card is unexpired at the end of this coming ski season, so March of 2018, it'll still be unexpired, you can...
Yeah, I'm good till September of 2018.
Okay, so you're in good shape.
ACLS and ACLS, actually. So.
Oh, okay, well, so you're way beyond.
Yeah.
But so all you need to do is show up at Refresher, or we'll probably do you early. You can probably actually do it Saturday if you want. All you have to do is demonstrate to an instructor that you know how to do 1- and 2-person CPR. You don't have to go through a little course, take the test, all that stuff.
Okay.
When your card expires, you have to renew it before the ski season starts.
Yes. Yeah.
At minimum of the BLS level.
Okay. Yeah, and then I'm an ICU nurse, so I'll have to renew all of them.
Okay.
Every 2 years.
Oh.
Too, so,
yep.
Yeah.
And the good thing is, and I mean, you may get it for free. I don't know, but generally our instructors at Ski Apache will recertify you for the cost of the card. I know I will. It's $7.
Cool. Yeah.
So.
Cool.
Yep. And so for everybody else, if you want it real cheap, be there Saturday afternoon.
Yeah.
Saturday morning is going to be all the skills we presented to date.
Cool. Okay.
Hands-on practice. So.
Oh, that's how I learned it.
Yep. So these, and by all means, as a nurse, you can certainly help instruct. I mean, I think it's perfectly fine for you to say, hey, look, why don't you palpate my abdomen, and I'll tell you if you're doing it right.
There's not as much muscle as there used to be, but
yeah. We'll just say my abdomen is not rigid.
Adipose, yes.
Yeah. There you go. So this session 6-3 is real important to make.
Okay.
6-17 is real important.
Okay.
6-24 is going to be your opportunity. I should mention this whole thing is optional. There's no specific guidelines around OEC as far as you have to make so many sessions or so many hours.
Okay.
It's almost instructor preference, which means it comes down to me. So if I've never seen you and you show up for the final, I can say, yeah, you're not taking it.
No way. Yeah.
But now you as a nurse, you can challenge the OEC course. If you challenge it, we have a higher level instructor that will actually give you a challenge. It's not really a course; it's more like a clinic. Mm-hmm. And then you take a one-day clinic and you show up at the final practical, final written. Mm-hmm. If you challenge, you have to pass the first try. You don't get a second try.
Okay. Yeah, I probably would just go through everything because, there are obviously splints and blankets and other stuff, that's.
And we do it different.
Yeah, so and I'm ICU, so we don't do that much. But
sure.
You know what I mean? Like, I'm not ER, but I do want to learn that. That's the thing.
Yeah.
That's awesome to learn. Yeah.
Well, and I can tell you too. My daughter, she took OEC. It was the first year of the 5th edition. And her entire class, she took it at a much larger patrol.
Okay.
And they had 30-some candidates. Although we're doing really good this year. We have maybe 12 to 16.
Oh, wow.
But anyway, so out of 30 candidates, 2 were non-medical professionals. Everybody else was EMTs and nurses, a couple of doctors. Awesome. And of the medical professionals, only 2 passed the written exam.
Yeah,
and
it's a different type of medicine that I've got to learn. Yeah.
It's all medical terminology. It's all there, but you might not get the mini dole question right. You might get, if they mention a quick splint, you might be thinking something different.
Yeah.
So there's enough that you don't want to take it for granted.
No.
And then your other thing is that I think all except for one of the professionals failed the practical.
Wow.
So there's just differences, like boot removal is totally different. In a hospital, you'd get out a saw and you'd cut a boot off.
Yeah.
We have a very particular way. It's slow and methodical, but it works really well. Yeah. And it saves the person's $1,000 boot.
Yeah.
Which isn't really the concern, but it's a nice thing to do if you can.
Yeah, I was a lifeguard all throughout high school and college. So I have some experience with backboarding and
sure. Yep.
All,
and we do that. We do that our own special way as well.
Yeah, it's so cool to learn. That's what I want to. It's so cool, exciting to expand my knowledge base like that. It's
cool.
I'm excited.
Yeah.
Yeah.
So you can see the other dates. There's not a whole lot of required, but I would say every Saturday, if you feel like going out to the hill, I've begged instructors, and I have good buy-in from everybody, that an instructor should be there to work through anything that you care to work on. Any given Saturday.
I believe. I'm sorry. Go ahead.
No, go ahead.
I am going to be starting in a new position in the ICU on June 5th, and supposedly I have to work every other weekend, but I'll still be in orientation for a brief time, so I have no idea what my schedule is going to be yet. So, but I'm going to, once I do, finally I'll be working 3/12s a week, so, it's not every single day, so.
And we can always work something else out with you. If you say I want to work on something, we'll just find out who's going to be out there. And it's always, weekdays are real slow, but, if you go out and Kathy's working with you, it would be, you'd be at her mercy. It would be, she might get called to go put up a fence or something, and it's like, well, okay, you're going to have to wait.
Yeah. Okay.
So this one should be very interesting. It's the mass casualty incident.
Oh,
You'll get experience. We'll do it with moulage and patients and the whole thing. Interfering people, all that. So, and for you, I would think I would double check, but if you wanted to volunteer to come out and do the triathlon.
Yeah. Well, that's my husband's birthday.
Yeah.
9/16. That'd be cool, though. Maybe he'll come up and party with me.
There you go. Well, the red dates, those are absolute mandatory because, like, here is the written refresher.
Okay.
So you don't want to miss that. We can work with you if you have a really good excuse for missing it. If you got to work, you got to work. Then we'll, work it out. But let's see. This one, the 30th and the 1st, I'm kind of depending on you guys to come out and be patients.
Okay.
But I would absolutely, like, even if you're, oh, heck, just be blunt about it. If you're lazy, like, I'm not doing that. That's extra, That is your opportunity. We refresh 1/3 of our skills, so 1/3 of that book every year.
Oh, wow.
And
okay. So
you will see 1/3 of the practical exam the way it will be done at the practical exam.
Oh, wow. That's okay.
So it's an amazing opportunity, and you'll see it all day. We're scheduling about a 6-hour session.
Okay.
You'll see it repeated over and over, and I'm okay if you want to swap stations and see one of the other ones. Just find one of your fellow candidates and swap.
Okay.
But you'll get to see it the way it's done with real patrollers, everything. It's almost like cheating on the exam. So
okay.
And I conveniently scheduled it 2 weeks before the final practical.
Oh, gotcha. Cool. How perfect.
Yep. So in between, I gave you a week off. You're certainly welcome to come out and practice if you feel like you need it. Anything special you want to work on. If not, I would take that weekend, relax, put everything out of your mind, because you want to come into the final practical fresh and ready to go, not all worn out.
Yeah. Okay.
And that final practical, that's the one that try to, if at all possible, take PTO that day or something.
Yeah, I can request time off. It's good to know the date time. Yeah.
It's way out in October, so you do get a chance if you take the full course. You get a chance to retake both the practical and the final.
Okay.
So the way the final works is you get there should be 5 scenarios. Could be more, probably not less, but it won't be 10. It's 5 or 6.
Okay.
They may be so, and it varies year to year. It's usually 2 full scenarios and 3 skill stations.
Okay.
So the full scenario is you walk into a room and they're like, "There's a guy laying on the floor. Go ahead."
Yeah.
That's all you get.
Okay.
The skill station is, I would like to see you set up an O2 bottle, insert an oral airway and a nasopharyngeal airway, and I don't know, something take a pulse.
Okay.
And there's no, you don't walk through scene size up, scene safety, sample, primary, secondary survey. There's none of that. Okay. So that's the structure. Now, every actually, and that's a good segue. So I'll get you the syllabus so you can review it yourself.
Okay.
If you go, you should see. Oh, and oops. Oh, that's mine. That's why. I gotta switch back to Ski Apache.
Oh, gotcha.
Oh, dang it. So when you go in, there's a candidate resources folder on Google Drive that I'll share with you.
Okay.
And let's go back to Drive. I don't want my account. No, I want Drive.
Yeah, I'm not familiar with that. But.
All right, we'll do it the long way.
I think it opened a new tab to the left.
Yeah. So here it is. Most of your stuff will be here under candidate resources.
Okay.
And you can actually, I think, if you right-click on something, I don't think it'll work because now I'm on as Ski Apache, but you can say add to my drive in this list.
Okay.
And then it'll just show up there. So now you have skill guides.
Okay. Oh, yeah.
So let's look at the skill guide for chapter, what do we do today? Maybe 9?
We went through, let's see, I think.
Oh, I guess we're beyond that. But this is inserting an NPA.
Oh,
so
cool.
see, you have to score 80% to pass this skill. So it tells you right here, must receive 4 out of 5 points. However, if you miss anything marked CPI, critical performance indicator, you fail.
Okay.
So, and like on this one, it wouldn't be possible to score 4 out of 5 if you missed any of these 3. So, anyway, so you can see for this one, standard precautions is your BSI, your gloves, eye protection if you need it.
Okay.
Insert the airway into the larger nostril. So here, that's a CPI. So if you don't do all these points in this part, you fail.
Okay.
Gently advance the airway. Let's see. This kind of goes with this, but it just talks about which way to face the bezel and all that.
Yeah.
That's actually in a previous session, so just go back and watch it.
Okay.
But say you forgot. Say you didn't size the airway. Okay, you could, but you inserted it correctly. You could still pass.
Okay.
I think 1, 2, 3, 4, 5. Yep, you can only miss 1.
Okay. Okay.
So, anyway, that's how the skill guides work. You'll see the skill guide for every chapter in there.
Okay.
Then you have quizzes. Did I put them? I think they're in here. This one. Nope. So every chapter, I've posted the quizzes. The quizzes, instead of making a quiz with like 10 questions on it, we've done that in the past. What I've done now is every chapter that we've finished, I've posted the entire test bank for that chapter.
Oh, wow, okay.
So it's possible, not easy, but it is possible for you to see every single question that's in the written test bank.
Wow.
So
I had that on like my nursing boards way back when. No, I was kidding.
Yeah. I mean, it.
No, I passed it on the first time, but still.
Sure. There's probably there's too many questions for you to memorize.
Yeah.
And they they randomize the order of the answers and they'll reverse the word order of the question. They'll, instead of which of the following is, they'll say which of these is not. But it's it's the same question.
Okay.
So the opportunity is there, and you have until end of August to do it.
Okay.
So if you review a chapter a week, a couple of chapters a week, just go through the test questions on the weekend.
Okay.
You probably could read them all.
Wow. Okay.
So, and you know what? Let me show you one. Let's do chapter 28 because we did that today. So see, here's the question. If you were to cover up the answer so you can actually take it like it's a real test.
Oh yeah.
Then you go, okay, I think it's B, and it says no, it's D. Then it's going to tell you it's objective 28-5. You can look that up in the book. So chapter 28, objective 5.
Okay.
And then it'll tell you can find this topic on page 903 and 904.
Wow, that's awesome.
So if you get it wrong, just go read that page.
Okay. Yeah. Yeah. Wow, that's awesome. Yeah.
Yep. That's how that works. Let me see if there's anything else I wanted to show you. Oh, you will. If I need you to buy the book.
Yeah, I saw it on Amazon today. I was kind of peeked at it, and I think I found it.
Okay.
I haven't bought it yet, but I will.
Okay. Yep. Once you've bought the book, just send me proof, like a picture of the cover or something.
Okay.
I will share with you this, which is one of our patrollers went through. His name is Barney Watson. You'll meet him later.
Okay.
He went through and scanned every chapter. And then he went through the chapter. See if I can find an example. Yeah, here we go. He's highlighted the important things you need to know for the test.
Oh my goodness! Wow, that's awesome.
Yep. Yeah, that was a really great thing for him to do. Well, there's Boyle's Law, like she was talking about. So just send me that proof that you bought it. I swore to Barney, because he doesn't want to get in trouble for copyright violations.
Oh, totally. I understand. Yeah, I understand.
So I swore to him I wouldn't share it with you unless you proved to me you bought the book. Yep.
Yeah.
The other thing that you're going to want to do is get the book and go to my nspkit.com.
Okay.
And I'm already logged in, but yeah, I mean, you'll set up a username and password, and the book comes with a code.
Okay.
If you buy a used book, you can buy the code for $5.
Okay.
And what you're going to do here is you go like, let's pick a chapter we worked on tonight. How about respiratory emergencies?
Mm-hmm.
Say go, and you can pretty much do all the exercises that were in the book if you think you need it. There's videos on how to do things. I would definitely check out the videos and things, but what we really want is word games for section review.
Okay.
And I think that was, let's see, what was that? Section probably 2.
Okay.
There's 3 different games. I'll just show you Quest for a Million. It's like how to be a millionaire. Who wants to be a millionaire?
Oh, yeah.
So your goal is to get to $1 million. You can't get anything wrong. So structure containing similar tissues that act together to perform a specific body part is called an organ.
Okay.
Report that includes circumstance leading to an injury is called a incident report. Circumstance leading, yeah. Okay. See when I go wrong. A blank is required to report the suspicion of specific crimes. Incident report?
Incident report, maybe? I don't know, I'm guessing. I don't know.
Let's try handoff. Oh, okay, well, I got it wrong.
You try again?
So then you start all over.
Okay, gotcha. Okay.
Anyway, that's that. There's other games in there. They'll help you get the vocabulary and some of the skills and things.
Okay.
So that's that. I'll get rid of Karka, candidate resources, quizzes. Oh, yeah, our slides will be posted here as well.
Okay.
They're also in this lectures folder.
Okay.
But I'll copy them over. I think that's mainly it for resources. Let me see if I can get this other one. It's if you go to groups.google.com.
Okay.
It hasn't been working real great, and I may switch it to like Facebook.
Okay.
Yeah. See, mine is weird because I have administrator rights, so it's not showing me the list of messages. Yeah. But what will happen is once you've joined the group, you can just send a message to the group, and it's SASP-OEC.
Okay.
Anyway, they'll have a link to it. If you send it there, it'll go to all the candidates and all the instructors, and then anybody can reply to it.
Oh,
so you can say, what's the normal respiration rate for an infant? And, somebody will post it back.
Okay. Wow, that's cool.
So,
very cool.
That's kind of that's the one feature that's not really working out real well.
Okay.
So I know Facebook has a similar feature, so I may just give up and switch to Facebook.
Yeah, I'm familiar with like Facebook stuff, but I'm learning the Google.
I know. I thought it would all be Google then, because you got YouTube and the Google Drive and this, and but it's yeah.
Okay.
Anyway, I think those are all the resources. Oh, so one last thing. What you need to do to get activated is you go to nsp.org.
Okay.
And it may automatically log me in. I'm not sure. It did. Oh, no, you're still okay. So even, whoops. Okay, well, now you can read my profile.
I don't see anything.
It was back at the home page. See this patrol candidates?
Oh, okay.
So what you have to do is click there. There should be a link here. Following steps need to be completed. So you have to, well, it doesn't tell you how to create an account, but I believe it's, when you're not logged in, there's a, create my account or a new member. You just do that, and you request to be added to the Ski Apache Patrol.
Okay.
Our patrol representative will get an email saying this person wants to be added as a candidate. As soon as he approves it, your account will be opened.
Okay.
Then you're going to go onto here, and we want to go programs.
Okay.
Oh, dang it. Education, OEC.
Okay.
Go to list of classes. I don't know if you can see right here. And then, no, it's had trouble finding ours, but let's see if it finds it now. It is not finding it.
Okay.
We'll have to find the course. No, that's Crystal Mount, Washington. That's weird. Like we used to see.
So close to us, yeah, where we lived. Yeah.
You know, yeah, but you should see everybody's. There's tons of OEC courses going on right now, and they should all be listed here.
Okay.
I'm surprised it's not.
Then you have to go to member resources.
Maybe. Let's try it. Education. Oh no, because you know what that's going to do? Yeah, see that's you wouldn't even be able to see this. That takes me to all my refreshers and.
Okay.
There was another way to get there.
I did it. I registered today, and I went through the member resources.
You did?
Yeah.
Okay. Well.
Okay.
And you were able to register for the course too?
Yeah, and you go, and it's just like the one you just went to, but instead there's 5 prompts, and you type in outdoor emergency care in full, and then it'll come up with all the classes.
Huh. Maybe it's just recognizing I'm not a candidate and won't let me take it.
Yeah.
Which is silly. What if I wanted to retake it?
Yeah. Interesting.
So, well, I would say give it a try. I've been noticing people getting registered, you know, as we've gone through, and if you have difficulty, there's people we can engage at the regional or national level to help us get you on through the website.
Okay. Cool.
So they're going to make you pay $60
okay.
to NSP for the course. That doesn't go to any of us. And then our patrol has a $35 fee just to cover materials, because we'll go through some first aid supplies and other stuff. Plus, we'll bring in a meal, you know, for the final exam and stuff like that. So.
Okay. All righty.
I think that covers everything.
Okay. Well, thank you. Very helpful.
Yep.
Very.
And I'll send you a follow-up email. It may not be today, but by this weekend, I'll maybe on the Hill. I'll send you a link or a list of links with all this stuff. So.
Okay. Yeah, it sounds great. Very cool.
Yeah, I think that'll get us going.
Hey, Jeff.
Yeah.
Jeff, this is Brian. What time Saturday are you supposed to be there?
Yep. So official session is 10 to about 2 or 3 o'clock.
Okay.
If I know Becky and Vann are planning to get there early, the Hill opens at 8, and so I think if you wanted to get there early and just grab somebody and practice informally, you're certainly welcome to do that. It will be a long day, but there's also a lot of skills to go through. So.
Okay.
Okay. Well, I don't know if I'm ready for practice yet. I haven't even read anything yet since I don't have the book yet. I'm still waiting for it.
If you can get out there, I would definitely do it, because we'll just, even if you haven't read it, we'll demonstrate the skills. There's not too many yet. The biggest one for this one is going to be patient assessment.
Okay.
So, and you want to work on that. That's patient assessment is where everybody fails the practical. They don't fail the big things. So.
Okay.
Okay. I'll plan on seeing you out there if I can then.
Okay. Yep, I'll be there at 10. Becky and Vann will be there early, and Hill's open till, I think, 6. So we're planning to stay until 3, but certainly can stay as long as you guys want. So.
Cool.
Yep.
Awesome.
Okay. Well,
I'm gonna run now, but I appreciate your time today.
Sure.
Yes.
We'll see you up there.
Hey, Jeff.
Okay.
This is Woody. How can I access the resources from Google? It said when I try to access it from one of the emails I've gotten from you, it says I need permission.
Okay, let me go back. I can just do it now. Oh.
And you don't have to do it now. If you want to do it later, that's cool too.
I can take care of it.
Okay, cool.
Except that it signed me out somehow. You know what? I'm just going to close this window. I have, we want here, drive. And the one you need is candidate resources.
Yeah.
Share.
Anybody
else need it? Wait, give me your address because it's not coming up.
Okay, it's I just made a Gmail account, so let me find it. I think it's Woody Louder, so just my name, 89@gmail.com.
Okay.
And is that the same? So once you do that for me with candidate resources, will that be the same with the other things like study aids and quizzes and homework and stuff?
Yep, they're all under that master folder.
Okay.
And I'll have to email you the link. You can also go to YouTube and search for Ski Apache OEC channel. It takes a little bit of hunting, but you can find it. Otherwise, I'll get you the link.
Yeah, I did find the YouTube channel earlier today.
Okay.
Yeah.
Huh? How come Eve isn't coming up? Eve, are you still on?
I am.
What's your email address?
Okay, it's CAFFEINE.
Oh, yeah.
at gmail.com.
Okay. That's a good one, yeah.
Yeah.
Anybody else?
I guess we're only 3 people.
I think that's it. I think I enabled you to reshare, so if you need to share it with somebody else, you can feel free.
Okay.
So, okay, you should get the link. I would recommend open it right away, otherwise it expires.
Oh.
And once you have it open, it's in one of the menus. You can choose Add to My Google Drive, and then it'll always be linked. So.
Okay. All right.
Yeah, I think that's it. And so you guys have the free conference call link. It'll be the same.
Yeah, I guess I do. I don't. We got it. Yeah, we did get it.
Okay.
We've gotten it, and we were able to access it. So yeah.
Okay. It'll be the same phone number and the same hyperlink every week.
Okay. All right.
So.
Okay.
Might bookmark it.
Yeah, definitely. Yeah. My husband's a little more computer savvy than I am, so.
Oh. Okay.
If you got our Cheerio line and art line, I'm fine managing that. But so,
sure.
Yeah. So okay.
Okay. Well, I think that's it. And then best of luck with the class, and we'll see you out there.
Okay. Thank you. Sounds great.
Okay. Sure.
Okay.
I'll see you.
Okay.
Bye.
Bye-bye.